Good morning. There we go. We're in business. Thanks for being here as our other friends continue to trickle in. We are so glad to be back in person in Seattle with the NBC Impact Series. My name is Tyler Pagel. I work for Susan G. Komen here in the Pacific Northwest, and we are thrilled for a day with you all. A few housekeeping items. Restrooms for the women are located just across from where you got your name tag. There's men's restrooms down the hall from the front desk. If you parked at the Hilton and did not receive your validation, we are validating all parking there, and so please see us and we'll give you a validation form that you can scan as you're exiting there. So I think those are the two things. Snacks and coffee, water, beverages will be continued to be replenished in the hallway just outside the main entrance. So please feel free to grab as many as you would like and keep your coffee and other drinks filled. So without further ado, I would like to welcome Annie McKenzie to kick us off.
Fun and games. All right, here we go. Good morning and welcome, everyone. My name is Annie McKenzie, and thank you for joining us at the NBC Impact Series. Today, we delve into the complexities of living with MBC, and I'm honored to be here with you. I approached Jennifer Weiss, one of the executive directors of Komen, to volunteer at this conference. I shared with her my history with cancer, and what captured her was the human and patient element in my experience that I can speak to. She trusted my unique perspective, not as a clinician, but rather a person living with MBC. Throughout the day, you'll hear from a lineup of speakers and community partners, each bringing valuable insights to help us navigate the challenges of metastatic breast cancer. I also encourage you to connect with your fellow attendees and speakers in this room. In this room lies a powerful potion of information and camaraderie that can ease our fears and alleviate stress. I understand the reality of living with METS, and it's often the elephant in the room. We face an invisible adversary, a road paved with uncertainties, anxiety, and fear, to name a few, in pursuit of prolonging our lives. Despite that odds stacked against us, we showed up today and are advocating for ourselves and others. I will tell you a little bit about myself. My story began at the age of 42 when I was first diagnosed with breast cancer. I had 12 years of remission, followed by metastasis to brain, bone, and lung for the past 6 years. It's easy to seek and despair with this diagnosis, but what anchors me is my incredible support team, my loving family, my friends, and my specialists at the BC Cancer Agency, and organizations like this that I trust and respect. I use exercise and humor to diffuse the challenges of living with cancer. It is a very personal journey, and everyone uses different coping methods to deal with their diagnosis. I have a short story that speaks to my coping mechanisms. In 2023, my brother Rob, also a breast cancer survivor, Rob, there you go, encouraged me to join the Komen More Than Pink Walk fundraiser at Woodland Park Zoo. Come on and sit down. Can everyone hear me? Okay. I was excited for a great cause and some exercise because that's what's been big for me in this journey. I headed south of the border with a good friend. I had done my due diligence by fundraising, planned my walking route around the park. I wore a pink sweatshirt and running shoes and ready to walk my 10,000 steps by my programmed watch. I should have paid more attention to the first two words of this fundraiser. More than. We did not have an anticipated, 10-kilometer walk for breast cancer, but a gathering of minds in a field, a sea of pink, food and speakers, and the inevitable photos at the end, as you can refer to right here. I had done my due diligence, fundraising, planned my walking route around the park. I wore a pink sweatshirt and running shoes and ready to walk my 10,000 steps by my programmed watch. I should have paid more attention to the first two words, more than. We did not have an anticipated 10-kilometer walk for breast cancer, but a gathering of minds in a field, a sea of pink, food and speakers, and the inevitable photos. My self-guided walk at the end of the day was watching zoo animals, and I've never disclosed this to my Canadian donors. What started as a lighthearted day ended with some sadness. For me, during the group photo, I found myself positioned front and center. Should I go over there? Okay. Yeah. Okay. Here's me. And I looked like I'm about ready to flee. And then we're surrounded by groups of survivors. And then there's us living with metastatic breast cancer. And then again, more and more survivors. It was really beautiful to watch. Okay, I'll go on with this story. What started as a lighthearted day ended with, I've already said that, sorry. During the group photo, I found myself positioned front and center behind a sign reading Living with MBC, along with only two others. Surrounding us were groups of survivors, proudly displaying their years of survivorship, and rightfully so. Two things struck me, however. The scarcity of people in my group. I initially was the only one there, and then two others joined me. And the fact that where did we fit in? It takes some reflection and the sensitivity to understand where MBC fits into our concept of survivorship and how to define us. Because we don't have a sign of survivorship there. I reassured my Komen friends that I did not take it as a slight. Instead, it sparked a conversation for the possibility of a new sign and maybe a deeper awareness. I dream of a day when MBC is a distant memory and survivorship is a reality for us. I want to stand behind a sign identifying us as MBC survivors, surrounded not by a few, but all of us. Now, there is a debate about new signage, and for now, I think the sign should say, still here. But I don't know, I haven't brought it up with Komen yet. And I just want to thank you for letting me speak to you today. I appreciate it.
Thank you so much, Annie. It was a beautiful day at the walk in 2023, and we hope you'll join us again in 2024 at the Woodland Park Zoo. You'll get your 10,000 steps in and lots of wonderful zoo animals. Okay. Yes, of course. Yeah, that. If you would like to join us at the walk, it'll be September the 28th again at the Woodland Park Zoo. A wonderful time of community, and of course some zoo animals. Oh, hey, there we go. The next speaker I have the privilege to introduce She's from Providence Cancer Center in my neck of the woods down south outside of Portland, Oregon, here to discuss navigating insurance. Please welcome Krista Nelson.
We'll have some learnings and some fun today. Okay, good. You can hear me. Oh, it's on. Yeah. Is the slideshow? Oh, perfect. Oh, perfect. Great. Maybe I'll go old school. There we go. All right. That's where I go to work every day. Well, good morning. I just want to thank everyone for being here. I'm aware that it just takes a lot to get here and to spend your time. And so I'm hopeful that our time together can be valuable. And I'm hoping it can be a little interactive. And I'm hopeful that if you have questions, I can answer them. So I'm an oncology social worker. I've actually worked at the same cancer center for 27 years. And most of that time, I've worked with women with breast cancer, or patients and families, I should say. And I think right now, currently, what I'm doing most is supporting all families going through cancer, but also doing a group for young survivors with metastatic cancer, as well as a group for men and women living with advanced cancer. So you can see my life's work has really been in supporting patients going through this just very hard time, but also a beautiful time. And so I'm hopeful that we can have some fun together today. I was thinking, okay, what would people least like to talk about? Sex, drugs, insurance. I mean, right up there. So hopefully today we'll have a little bit of fun. So I don't have any disclosures, but I'm curious kind of who's in the room today. Like how many people here have been bothered by what they're spending on cancer treatment? Yeah, okay, good. So we have that in common, hopefully, maybe. I mean, I get there's a balance of being grateful for the treatment and being grateful and kind of the stress. And one of the things I want to talk about today is financial toxicity, because it is actually a huge side effect of having metastatic cancer. And that has to do with insurance, it has to do with disability insurance, cost of prescriptions, all of that. So I'm going to talk a little bit about. Are there people here who are still working with metastatic cancer? Okay, great. Thank you. And does anyone wonder, should I be working? Does anyone have that? Yeah, okay, good. These are things that come up when I'm working with people with cancer, so I'm hopeful that I can kind of have that discussion. I'm going to start out with a personal story. This is not a picture of Shelly, because I couldn't find any without her whole family in them, but one of my best friends is also living with metastatic breast cancer. She's my same age. Her dad is an oncologist, or her husband, sorry. And their children, they have a rare genetic mutation called Li-Fraumeni, and she's had metastatic breast cancer for, I think she's going on 4 years now, and it's just in this process of changing treatment right now. And how many of you have been in that process where one drug is not working anymore and you're waiting for authorization for another one? Yeah, it's so frustrating, right? So she's in that mode, and I think just how she is trying to stay in the moment and live and be and balancing with waiting to get the next drug, to start finding this. And then I think the angst of what that means. And, she is very fortunate. Her husband is a doctor, and they have over $6,000 of medical bills a month because of their mutation and the scanning that their children need and things. So I wanted to start out by talking just a little bit about the state of finances. And I know it can feel personal to talk about money, but I also think it's very important. So, who is it? The Federal Reserve does a study every year, and this is actually data. It doesn't come out till, I think, May this month for last year, but this is 2022 data. And they ask the question, if you had an unexpected expense of $400, would you be able to pay that? And the truth is, 63% of adults say they could cover that with some savings or a credit card and be able to pay it back. But, 13% said they couldn't cover it at all, and another 27% would have to borrow the money. So you think about $400 a month, and you think about these drugs that cost $14,000 a month, and kind of what the angst that brings. And I think sometimes this fear of bringing it up to your physicians or your medical team, thinking maybe you won't get offered the best treatment because maybe you're worried about costs. So I'm here to kind of dispel some of that, encourage you. So I'm an oncology social worker by training. I'm going to say, leave here and find an oncology social worker where you're getting treated. I know if many of you are from Seattle, Swedish has lots of social workers. I'm sure everywhere you did. But even when we talk about households and we talk about medical expenses, 23% of adults had major unexpected medical bills, and 16% had unpaid debt, and 28% of adults skipped medical care because they were unable to afford the cost. So if you're feeling like you have these bills, and how many people have a pile of, what are they called, EOBs? Yeah, there's a pile where it's like, oh yeah, this is an insurance pile. I'm gonna just avoid that and hopefully it'll all work out, balance out at the end of the year. 100 million people in the US are experiencing medical financial hardship. So thinking about that. So when we think about financial toxicity as a side effect of cancer treatment, which I like to think about, hopefully your cancer centers are addressing this because we're addressing your pain, your fatigue, your nausea. How about your financial hardship? Because it is a huge part of the care that we're providing. And it's not just the direct medical costs, right? But it's transportation, it's finding childcare, it's not watching your grandkids. And then what about the time you miss from work and taking vacation time and things? So all of these kind of play into it. And what are the risk factors of financial toxicity? How many of you guys see yourself in this list? So if you can see it. So advanced cancer. Having comorbidities, which mean, just other things that can even happen from your cancer treatment, getting chemotherapy or radiation, being female, younger, lower income, maybe your race, and then your health insurance. So I want to talk just one slide about debt. And I think this is a hard slide for me to read. So it basically is saying, many people go bankrupt due to cancer treatment, and many families get into a bad place financially after their loved one dies of cancer. So I think so a third of households exhaust their savings, and 22% reported that the treatment was a major financial burden after someone had died. So I want to start out just by talking about insurance. So, because that's what the title of the talk was. And how many people, so we have private insurance. Does everyone know what that's like if your work pays for it or maybe your partner's work? Then there's Medicaid, and that's based on, and it's expanded now in the last few years, so a lot more people can get on Medicaid. And that's mostly based, I can speak mostly to Oregon, but on your income and not necessarily the savings that you have, your availability. And I think Medicaid and Medicare are excellent insurance to have. Medicare is often available to you if you're over 65 or if you've been disabled for 2 years or longer. So just a question for the audience. What do you guys think the answer to this is? An insurance blank is the amount you pay each month or each year to keep your insurance policy active. Premium. Awesome. So I'm going to spend some time going through defining what all these, does someone in the room know what all these mean already? Because you can help me. Okay, good. Oh, there's some experts. Good. So premiums, exactly. That's what you pay every month to keep your health insurance, or your person does if it's a private insurance. A deductible, that's the amount of money you have to pay before anything else kicks in. So most people in this room, I guess, have hit their deductible by now. Right? January 15th, get that bill, right? It's like, yep, I've got that. Okay, co-pays. So this is the amount. This can vary. And the lower, I think, the lower your premium is, the less amount you pay every month, the higher things like your co-pay might be. It might be $50 to see a specialist instead of $5 or $100. You have to pay that every time you see that physician. And I think sometimes our medical partners forget that. I mean, if they're late or they don't give you your whole 20 minutes, it's like, I'm paying $100 plus my insurance, really kind of just to be with you and to kind of spend that time with you. Co-insurance. So that is often if you have an 80-20 split, or a lot of times that's the amount with Medicare if you have straight Medicare. So that is a percentage you have to pay forever unless it has an out-of-pocket maximum, which would be my next, yeah. So that means every medical visit you go to, say if it's $100, your insurance pays $80, and you always have to pay $20 or 20% of that. Max out of pocket. I think these are helpful terms to know and helpful to know about your own policy because it helps with anxiety. So if you think, oh my gosh, I have to pay 20% of all my medical bills and I'm getting all these drugs, but you forget to look, oh, my max out of pocket is $2,000. It's like, okay, I have to pay 20% up to $2,000. I can do that, or at least I know what's out there. Okay, all of this with a caveat. I took a picture. Most hospitals, so this is important. This is going to be hopefully something you guys are like, oh, this was good information. Most hospitals have financial assistance programs that you may or may not know about. And I can speak Providence, which I assume Swedish is the same, is up to 400% of federal poverty level. There is some discount. Below 300% in Oregon, it's 100% write-off. So I pulled what federal poverty, what that dollar amount would be. So if you are a family of one, it would be $60,240 a year. For a family of two, $81,760. A family of three, $103,000. So a lot of people that I work with make less than that because they're on Social Security, disability, or that. And so if you have these kind of large balances, systems often look at your income and the fact that it's a catastrophic health event. So I would encourage you to apply for financial assistance. The forms are online for all the hospital systems, and get in there and look at getting some of those paid for. So has anyone ever heard of this before or known that? Okay, so good. The other thing is, I'll just pop in here so I don't forget, is for financial assistance with prescription drugs and things. Those are often much more generous. So the financial assistance available through pharmaceutical companies, those are often 500 or 600% of federal poverty level, which is for a family of one, $75,300. Family of two, $102,000. So you can have a pretty significant income and still qualify for assistance coming from a social work perspective. Okay. So out-of-network costs. I'm sure all of you know what that is or have been hit with that, right? Like you get a test result that gets sent, you had no idea, and then suddenly you're getting a collection from a bill because you didn't have a way to know that that was in contract or not contract. So out-of-network benefits can be tricky. It's important if you're going for second opinions to a different system to really ask to speak to the financial counselor so you understand what your bill will be, what you will be responsible for. I will say that health systems and doctors' offices and clinics are getting much better now about providing financial assistance because the government has and some regulators have kind of mandated that they do have an ability to tell you what your cost will be. Non-covered services, that can be different for different people, but I think when you think about non-covered services, when I think about the people that I work with, it's often acupuncture, naturopaths, all the things that kind of can help support. Although many systems are recognizing that now, or health insurers, and are able to pay. Then you think about prescription benefits. It's a totally different benefit now, as is mental health, as is DME, so things like prosthesis, lymphedema garments, all those things. So just even going over that, it's like, oh my gosh, you've had to become experts in insurance, and that is complicated. So if you do have any questions or you're curious about the insurance you have or if you should do something different, there are places that are available to help you get health insurance. So one resource I use in Portland are these insurance brokers who sell different plans of Medicare. And the truth is, they don't cost you anything. I think they get a kickback from whatever policy you end up picking. But there's some really good ones out there, and they can really help you. What drugs are you on today? What doctors are important to you, and what Medicare Advantage plan probably would be best for you, or Medicare plan. There's also financial counselors within the clinics and the hospitals, so I think those are good people to reach out to. And then, starting in 2014, they got rid of, I've been doing this for a long time, and it used to be that people that I worked with metastatic cancer could not get health insurance because they had a pre-existing illness. And they had these like high-risk insurance pools, and they cost like a lot back in the day. And now, luckily, that isn't an issue anymore, but it's still something to look at the exchange as well, and brokers can also help with this. So there's some good videos online on this website. So I put that on there in case anyone is interested in that. Okay, so there's medical care, and here's some lists. I know it's tiny, but I just wanted, and this is actually, some of this is off the Komen website. So there are some resources available to help you pay for some of your treatment, especially the Lazarex. I don't know if anyone's used that foundation before, but it's great, and it's for if you're in a clinical trial. And if you have an oncology social worker, and ask them, but if you don't, ask for an oncology social worker, because someone can help advocate and help navigate all of these systems for you. They can't fill out all the applications for you, but they can tell you kind of based on their experience, kind of who's been giving money recently or who may have some funds available. So, but I think number one, the bang for your buck is really applying at the clinic you're being seen or the hospital you're being seen, because most people can get some discount for that. And then how many people are on an oral treatment for their, So this it's so complicated right now, right? Because is it being billed under a chemotherapy or is it a prescription? That really has a huge impact on what your copay is. The great thing is a lot of pharmaceutical companies, some people will say, oh yeah, they told me it was going to be $20,000 a month, but somehow I pay $25 for this key, with this card or something. There's a whole army of people probably working on your behalf, probably asking you for income information, trying to get these different programs from these different pharmaceutical companies. So again, do not be, I know it can be hard to ask for help and hard to know, do I have the resources for this? The truth is, if there is someone else to pay for that, let them do that and use your money to do something fun instead of pay for medication. So when I think about financial toxicity, I'm going to probably fall off the stage. I usually move around a lot. Sorry if you see me. Yes? Yeah. 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 Yeah, the donut hole is a little smaller. Yeah. Mm-hmm. Yeah. They also kind of made smaller the amount of money you have to spend until you get the full coverage. Yeah. Yeah, so if you have Medicare, Part D, they made some nice changes this year. I mean, still not perfect, but it's better. Yeah. So when I think about financial toxicity and you think about time away from work, and then there's also all these other things that get in the way, like transportation. Maybe you don't live right in a city because you didn't expect you were going to have metastatic breast cancer, right? That was not in your plan. And so there are also some resources for things for transportation. So just encourage you to look at these resources. It's so important. It's also important to know it's okay to ask for help. Everybody needs help sometimes. So I worked with this little boy who's 5. His mom had metastatic breast cancer. I used to do this group with him, and he said, well, Krista, everyone needs help sometimes, even Superman. And I was like, oh, I'm going to use that in the future. So I quote him quite a bit. Yes? Uh-huh. Okay. The Kathleen Sutton Fund. With a K. Oh, that's great. Can everyone hear her? Okay, good. Yes. Thank you for sharing that. And again, I will just say I live in Portland, so I tried to just give more national resources, but also, it's on the Komen website. I think. I think it is. Yes. Yes. Oh, perfect. If that's helpful, you guys can have my slides. Okay, cool. Because they are live links in there, I think. Okay. Then there's also just personal expenses like rent. And also, did you guys know there are college scholarships for people with metastatic cancer as well as people with children who have metastatic cancer? So just know that that's an option. If you're a younger adult, there's the SAM Fund. They even pay for things like gym membership. I think it's called the SAM Fund. Yeah, the SAM Fund. So, just kind of knowing there's a lot of resources out there in the world to support you. So kind of when we are thinking about insurance, I want you to think of another resource. Is all your insurance companies now have insurance case managers. This is kind of a new phenomenon. They've always had them, but now there's a lot more of them. And let's be honest, they're there to make sure that patients are using their resources appropriately. They're trying to keep people out of the hospital. They're trying to, remove any barriers that might send you into the hospital or not able to get something soon. These people can be incredible advocates for you. Now, when they call, it can be confusing because you're like, who are you? Someone laughed. You're right? It's like, oh, this is Betty from, and you're like, who are you? And what do you, but they really, they can help navigate especially if you're having trouble with pre-authorization or that. They're a great person to just be kind to instead of annoyed. I know maybe that's just me speaking, but I'm like, who are you? What are you calling? So anyone with an advanced cancer diagnosis, so metastatic breast cancer, you probably have one assigned to you, whether you've connected with them or not, but it's a good person to reach out to because sometimes when you're trying to get these pre-auths and these things happening, you can have your physicians advocating and they're working hard to get you whatever they can. But it also, sometimes I feel like the patient perspective inside kind of kicks things up a little faster. And so just kind of use them as a resource if you need something. And they're lovely. I mean, they're pretty nice to talk to, too. So I just was talking about with someone else out here recently around this. I think a big discussion I have all the time with patients with advanced cancer is, should I work or should I not work? Like, when do I go on disability? Am I going to be able to pay? And there's a lot of great resources out there. I think my two favorite is Triage Cancer. They're phenomenal. You guys should remember triagecancer.org. They have all these one-pagers. The women who run it are incredible. And then Cancer and Careers. And I think when I'm working with people and they're making this big decision about should I stop working or not, number one is always finances. Like, what does your disability at work look like? What is this Social Security disability? Do I qualify? I'm going to go into that a little bit. I hope that's okay today. I know there's some people who are probably already on disability, but I do think it's helpful. But it's also like many people find their meaning and their connection through their jobs, their life's meaning. And so that is really, so it really is a personal choice. I will tell you, I work with people until the end of life. There are very few people I meet, in fact, no one in 27 years that says, I wish I spent more time at work. Nobody has ever said that to me. They have filled their life with other things. Sometimes people have to stay working, and that's okay too. But I think, thinking about why does the work matter for you? Do you have meaning in it? Is it around providing for your family? And what are your financial implications? And is it a healthy distraction? Or is it taking away? Is it causing stress for you? These are all kind of things to consider. Number one, do not reduce. I try to not give advice. I'm going to give you advice right now. Do not cut your hours at work to make up for your illness because of this reason. If you're a full-time employee and you reduce to part-time because of your metastatic breast cancer, and then 6 months later you decide to go on disability, your disability payment is going to be on the 3 days a week instead of the full-time. So everyone I meet always goes part-time first, right? That's what we do. We reduce our work. So it's just something to consider financially. If you're reducing your work because of your illness, consider applying for some sort of leave so you're getting disability for part of that time in the time where you're figuring it out. Now, if you decide, I really just want to work part-time right now, that's fine. But I want you to think about the impact of reducing your work. This actually came up with a physician I'm working with advanced cancer, and she is pretty sick. And she said, well, I'm just going to work, 2 clinic days a week. And I'm like, please call me. Do not do that. And so I talked with her, and the truth is she came back and said, wow, I never really thought a social worker would be one of the most helpful people in my treatment team. I'm like, really? But she said, but actually not going part-time saved my whole family financially, because then now she's able to get full-time disability pay. And so I think just thinking about that a little bit. So I want to talk about disability. So say you're thinking about stopping work. Is anyone thinking about, if you feel comfortable, okay, someone might be thinking about stopping work. What does it all mean? I think number one, to qualify for disability, in general, health disability, a diagnosis of metastatic breast cancer, you qualify. No question about how well you're working. No one is going to question metastatic breast cancer for disability, not even the federal government right now. Okay, so I'm going to talk about the federal programs, and this is a lot of words, but disability with Social Security for disability, Social Security disability, really in general, is you have to be disabled for 1 year. That's kind of how the government makes determination. And you may hear a lot of times, oh my gosh, so-and-so applied, they had to get an attorney. I tell everyone with metastatic breast cancer, advice again. You guys are never gonna invite me back. Do not get an attorney. You qualify for. Now, Social Security, there's a few things that also have to be true. You have to have paid into Social Security. So you have to have met what they call 10 quarters of coverage. Most people have worked for somebody else who's been paying their Social Security. Sometimes if people are independent or they've worked for themselves, they may not have paid the second half. It gets complicated. Back in the day, Social Security used to mail these statements. They were green and white, and it said, oh, if you're disabled on this date, you get this much money. Right now, they only offer those online, so you can all make your own online account, and you can see if I were to be disabled, what your retirement ages be, and what disability is typically from Social Security is basically your payment at full retirement age. And then at full retirement age, it switches from disability to Social Security retirement. Okay, so how do you meet criteria? Metastatic breast cancer. Inoperable, multiple stages. Now the thing is, say you've applied for Social Security, or you're thinking about it, and the number one thing is, what's your date of disability? That's what they always ask. So that's the date where you reduced your work or stopped working due to your illness and had a diagnosis. So both those things have to be true. So a lot of people are working full-time. They have metastatic breast cancer. They're like, I'm going to go on disability today. That's kind of your date of disability if you've been working, because disability, it has to be two things. Your inability to work full-time and having the diagnosis. Is that making sense? official? Okay, oh, amazing. Okay, so here's the definition of breast cancer specifically. You guys can Google, this is what I do, Social Security Blue Book. And that thing right there, you click on adult listings, and number 13 says malignant, then there's one for breast. Basically, it gives you exactly what you have to have. And the diagnosis, I can tell you, of metastatic breast cancer is absolutely on there. The other thing to know is that you can get your disability approved sooner with breast cancer. They started something called compassionate allowances. So in your application, whether you do it online or you give them a telephone call, you want to say, I qualify for compassionate allowances. It'll say other news. And basically, it's very black and white if you have breast cancer, if you qualify or not. So you just put that in there. It will mean your application should be fast-tracked to get approved. Caveat, that does not mean you get your money faster. Okay, so everyone's like, oh, I'm fast-tracked. So here's the deal. Social Security, most people don't know, you don't get for about 5 months. So if you're thinking about applying for disability today, and you work for somewhere that has short-term disability, no problem. Now, your state here in Washington also has short-term disability, but it's often only 3 months. I think it's 3 months here. Oregon has 3 months too. So there's this like 2-month time period where you may not have income. You also have to think about health insurance during this time. Okay, are you guys ready? I want you to listen to this. If you apply for disability and you have insurance through a private person and you want to continue that, you want to stay with your employer's insurance, people will say, oh, you can have COBRA 18 months. You can actually extend your COBRA up to 26 months if you have a disability. But you have to tell your COBRA administrator when you're approved. So you could literally keep your COBRA until your Medicare kicks in, which is insurance. Now I can see people's eyes starting to flood over. This happens every day when I have this discussion with people. But the key is you don't have to be an expert. I just want to tell you these things so you keep mindful and know that there are advocates for you where you get your cancer care who can help you kind of navigate some of this stuff. Yes. Oh. Okay. Well, that is unfortunately very common. There is no way to get additional money for your breast cancer diagnosis for your through the government, other than to look at individual resources. So, for instance, someone who's living on just limited income with Social Security, I would expect that person not pay any money for their cancer care. I would hope that they were getting all these things paid for. They might be getting support from food stamps. The Cancer Center might have pots of money to help people pay for rent. There's a lot of resources out there to kind of, if you are in a place where you're waiting for money to come in or you're having this kind of short term as you're waiting for your disability, there are a lot of programs that can help people in that stopgap, in that time when they're waiting. So just again, find a social worker. They're going to be a good advocate for you to let you know. It may be that they can't change, and it may be that you have to look at a different housing situation. So with a diagnosis of metastatic breast cancer, you can go to, you could potentially be up on a list for affordable housing because of your diagnosis, and you may be able to move into somewhere where you only have to pay 1/3 of your income for your rent. Not easy when you're going through metastatic breast cancer treatment, but not something to not look into if you're really struggling. Thank you for your question. Yes? Wow. Nancy's list. Sounds like there's a lot of really good resources out there that I may or may not know about. So, and that's the truth. I think just reaching out and asking, maybe at your networking lunch or something, you guys can connect around different resources as well. In the moment of time, I want to move along. So, I also want to talk about life insurance. So, if you are working for somebody, a company, you probably, hopefully, you may have a life insurance benefit with them. Did you guys know that many of those have an accelerated death policy, so you can take all the money out, even though, and you don't have to pay it back if you don't die in 1 or 2 years? It's fascinating, and people don't know about it. Now, one thing, the caveat is, if you're getting free medication support, and then you suddenly have an influx of money, you want to be careful about that. And so this physician that I was just working with is taking out all of there. But then I said, completely out of my scope, you should get a trust. So I am not an attorney. I am not a tax specialist. But I do know that there are ways to protect you and the resources for your family if you get an attorney. And I don't really understand that. I don't have enough money to hide any money from anyone. And if I did, I would get an attorney because I know that they could help me. So there are some free resources. Again, Triage Cancer is run by attorneys, and they're great women, and they can problem solve with you about some resources and things. Also, there's just some other ones, and it sounds like now we're going to send this out. So there's also money through the SAM Fund if you're 39 or under that can pay for legal fees. There's also a lot of attorneys in town who will support you for free. The social workers probably know somebody. So if we've had people, kind of their cancer has progressed in a way that we weren't anticipating. They're in the hospital. Things are kind of a crisis. Never when you want to be making decisions. But if that was you, you can have attorneys come to the bedside and help support you. I'm going to pause there. Any questions? Yeah. Mm. Mm-hmm. Mm-hmm. Mm. Mm-hmm. 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 Yeah. Yeah. There hasn't been a lot of progress. Right now, the shift in cancer advocacy, I have a little bit of a role with that, has been more around drug shortages, which is also very important, access to the chemotherapy, and some of the prescription costs coverage. And but trust me about the 2-year. I think the health exchange, though, hopefully you have found a way to get insurance or a. Oh. So hard. Mm. Yeah. It sounds like something, yeah, sometimes I hear this, where things don't go exactly as they should, but in general, with compassion allowances, they're supposed to approve you within like 12 days. So, but you still don't get the money sooner. Uh, You don't get back pay. Some, I will say, some people, yeah, you get after 5 months. Some people have gotten back pay, and that's been based on if maybe they had gone to part-time earlier and things like that. When you get on Social Security, you can also continue to work. After you're approved, it's called Ticket to Ride. You can find all the information online. You can make around $900 a month for 9 months, and then they'll look at it again. But I just really want to thank you for sharing your story, because it really puts to home what we're talking about, how hard this is and complicated. And please don't navigate it alone. You know, we're here, or my colleagues, I'm sure, will be there for you. So because I had a few more minutes, I'm just going to talk about a couple things that I also really feel are important and maybe aren't about insurance. But I, for many years, focused on working with kids who had a parent with cancer, or, you know, even a grandparent with cancer. So did you guys know that 1/4 of people going through cancer treatment have kids 18 or younger at home? This is a population that we are not supporting great. Even in all of you, I'm sure, have a kiddo in your life, whether it's a neighbor, maybe you're a teacher, maybe it's a grandkid or a niece or something. You have children in your life, and a lot of times parents and people are paralyzed. Well, how do I talk to them about being ill or cancer? And I think it's like we want people to understand who we are and what we're experiencing, and we don't want to scare, and we want to protect children. And so I think I hear all the time, I don't want to scare my kid, I don't want to talk. And I just want to say, I worked with kids for a long time in this program for kids whose parents have cancer, and they already know. And the way they get their information is very savvy. So one kid's like, oh, if you need information about your parent, you just put that number in the phone, you look at who they texted their bestie, and that's where all the information is. I was like, or people say, I found out from my best friend because our moms are best friends, and my friend sits on the stairs and listens to the conversation and then tells me. Yeah. And and food showing up. Yeah, it's a giveaway. Hmm. Yeah. 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 I think the pressure of holding a secret, right? And just like the legacy you want to leave with your families is that we tell the truth. So I just have some advice real quick to give more advice. I'm almost done. You guys can stop listening to me in a minute. Well, I almost fell off again. Okay. So a lot of parents tell me they're afraid that the kid is going to say, are you going to die? And so I'm going to give you the words that I give all the moms and dads and grandparents, and you guys can take them or leave them. But I think the conversation could go something like this. None of us know we're going to die. But I want you to know that the doctors don't think that's going to happen right now. That's why I'm getting chemotherapy. You want to use real words. You don't want to say medicine, Because Lord help you the next time you try to give them medicine. They're like, I don't want my hair to fall out, right? So you want to use the word chemotherapy. Or that's why I'm getting surgery. You know, those words are scary to us. They're not scary to a little. And say, you know, they don't think that's going to happen. But what I want you to know is if that changed, I would tell you. And kids are like, oh, okay. Because the truth is, everyone here is living with metastatic breast cancer. You know, at some point, this disease may take your life. And talking about that does not make it happen sooner. And I think we get in this place of kind of being afraid a little bit to go there. And I just want you to know, if you've been, most women and people that I work with do tell me they've been thinking about it, but they haven't had anyone to think about it with out loud. You know, so finding a social worker, talking to your oncologist, you know, they care, they understand. They want you to be well as much as you do. And to kind of prepare is not change the outcome. And it actually will help your family and your kids. So just one slide on legacy work. There's all this energy around, if I do die, what do I want my legacy to be? Right now, you being present with your families is enough. Do not put this pressure that you need to have these letters for every birthday or significant day or videos or, you know, I did have one patient a long time ago make a bunch of videos and she, and cards, and then she ended up opening those with her daughter every year. You know, it's been like 15 years, they're still opening these letters. I want to say one caveat is because I have been doing this a long time, I did have a daughter of a patient that I saw for a long time come back and ask me what I thought because her mom had written her a letter for when she got married to a man, and turns out she's a lesbian. And she was, do you think my mom would have loved me and accepted me? You knew my mom. Of course, like totally out of boundaries and anything I'm supposed to do. I'm like, yes, your mom would have loved you, of course. But so thinking about the words that we use are important and also kind of make it more convoluted when you think about kind of writing these letters. So I just wanted to put that out there. There's also this thing that, so I do a group for the Young Survival Coalition. Actually, I've done it for like 10 years, women under 40 with stage 4 breast cancer. And we talk a lot about just the planning of death, even though we're hopeful that doesn't happen, but what to do. And there is a thing out there, you can Google it, called a death dossier. And this is my cheat sheet list, so I'm glad you're gonna get it. But there are all these things that I hope you do. So I used this list when COVID came out, because I was in the ICU with people with COVID. Like, none of us know when we're gonna die, and we should all do these things. Like, what's your Facebook password? Maybe you don't tell someone now, but you have a place where it is, because that will haunt people for years if you're not here, right? Like your student loans can go away, all these different things. So it's important to kind of have all that information in one place. A gift you can give to your family. You don't have to talk about it for a long time, but work through the list. Like, get it down. I just encourage you, this is available, and to consider that if possible. The last thing I was just going to talk about is advanced care planning. I know there's some people talking about palliative care today. Again, talking about this does not make anything happen. What's most important to me is, who do you want your decision maker to be? If you can't speak for yourself, who do you want your medical team? Because by law, if you're single, it might be your oldest kid, which may be the last person you want making decisions for you, right? So by law, there's a list of priorities. So if it's your best friend, it may not be your partner. They might not be the right person for you. All right, that's all I have. Does anyone have any more questions for me in the last minute or two? Yeah. 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 You did. Can't make a dream, or? Okay. There's also Harmony Hill. I don't know if anyone's been here. It's great. It's right near here. So Okay, I just want to take a moment. Let's just take a breath. Covered a lot and a lot of big feelings and emotions. I saw emotion coming up in the room. I want you to know I care about you. I know your medical teams care about you, and Komen cares about you. That's why they're having all this information here today. So thanks so much. Be gentle with yourselves. Take the breaks that you need during the day. And I just wish you all well.
Welcome back. Welcome back. Excited to continue our day this morning. We'll have several more built-in breaks throughout the day, and then, of course, a long lunch hour to join. So our next presenter is someone very near and dear to Komen. She sits on our Washington Advisory Board, and every time I'm in public with our next presenter and a patient sees her, they are just over the moon to have run in to their doctor, which I think speaks volumes and testaments to our next presenter. So I have the absolute privilege to introduce Dr. Fenteng Yan.
Thank you, everyone. I think I know most of you, and thank you for being here. It's my privilege to know you, be part of your team. You have no idea how you guys changed my life. So I just want to thank you, everyone, for letting me know, be part of your team. When everyone was looking at the schedule today, I got asked multiple times, Dr. Yan, why are you talking about mental health? It's not your expertise. Why are you talking about it? It is not. I'm not a psychiatrist, and I'm a medical oncologist. So I went through my PhD, postdoc training, residency, fellowship. I am a very data-driven person, and I'm very scientific. And I used to think I'm a very tough person. I was raised in a way that you're a tough woman. You got to tough everything out. That's how I think I am. Until in the past 2 years, I went through a lot of mental stress myself. And this is how I felt, and I realized that actually mental health is so important. I'm still working on it, and I'm not shy to share that this is how I actually understand the mental stress better, and I'm willing to work with everyone to handle and manage and cope the mental stress. So I just want to see everyone here. How do you feel today? Who feel angry today? Anyone feel angry today? Good, good. Anyone feel calm? I'm okay. Who feel calm today? Good. I'm very good to see that. Who feels absolutely happy today? Good, good. Or, may you be like me, I have a mixed feeling. I feel calm, I'm happy, but at the same time, I still feel proud of myself. I'm a little bit tired. I had a long week, right? Yeah, so, the reason I want to emphasize the mental health is actually we have good data and study to show women with breast cancer and mental health at the same time, they had a 36% higher mortality hazard. So think about that. You are battling with the diagnosis, side effects from the treatment, and at the same time, you have all the emotional stress. How can you cope with the diagnosis and side effects? So this is how I do not think we emphasize the mental health enough. And as a medical oncologist, I want to admit that in the past many years, we focus on the diagnosis. We focus on the treatment. I have these treatment options 1, 2, 3, 4 for you. How dare you say no to me? How dare you not get my treatment, right? So, I think especially as a community and our family and the doctor sometimes can get angry and mad that you are not getting the right treatment. How dare you? But, just imagine if a person is depressed, is stressed, it's hard. for them to process any information and to cope with any new information. So, for me, the mental stress, has nothing to do with MBC, but I think, I went through this similar coping mechanism and the process, so I can totally understand how may you feel when you are telling me, Dr. Yan, I feel stressed today. My mom was diagnosed with acute leukemia back in 2022. So that was COVID. She lived in China. And that's when I realized when I need to see her, I actually had to be quarantined for a month before I can see her. So for what I do, and I had to take 2 months off, and every patient here of mine knew the story. So I took 2 months off and quarantined for a month, and I finally saw her. She was 70 pounds. She was suffering. I saw her 3 times, and she passed away. And the day after the funeral, we brought my dad to the doctor, and he had cancer. So I'm still emotional to talk about that, because I'm still recovering, I'm still grieving. And right after I finally felt, well, I'm getting better. Yeah, if anyone knew me, my lovely sweet nurse was killed by a gunshot last summer. It was on Seattle Times and everywhere. So, and on the day of her funeral, I was in LA attending the funeral, and my 15-year-old son decided not to want to live. So I'm emotional, right? How can you not be emotional when you have that big stress, right? So, this is a common mental stress that we often the time did not realize it's so important. When I was going through all that mental stress, and everyone was like, how did you cope to come back to work? And my answer was, I had no choice, I had to. But retrospectively, I don't think I did a good job to take care of my son's mental health and my own mental health. This is how that I think, we should work together, realize how important mental health is, and we should prioritize our mental health. Not to give up your medical treatment, but at the same time, we have to really prioritize our mental health. So emotions after an MBC diagnosis, and I went through all those stages myself too. We are in shock, and we cannot believe it's true. And when I first heard my mom's diagnosis, my reaction was like, no, that's wrong. Something has to be wrong. Send me the report. I want to read it. And I want to call up 20 pathologists. Something was wrong. This is wrong. This is ridiculous, right? That is a very common reaction. And of course, we would have those fear and uncertainty. What's the next step? What's the treatment? And is she going to live? Am I going to live? And how is the treatment looking like? And of course, there are a lot of worry and fear and uncertainty. And also, we often the time, the most frustrating part is the feeling of loss of control. We're all controlling freak, right? We want to control. We want to control our job. We want to control our husband. We want to control the kid. We want to control everything. And we feel good when everything is in control. But when a diagnosis of MBC was delivered, and that's when we felt we lost control. We no longer are in control of ourselves. That feeling is awful. And of course, we can be in denial. I'm still in denial. I'm still talking to mom every once in a while. I still feel she's somewhere and talking to me. And angry. I was very angry for quite some time. And if a dear friend said the wrong thing at the wrong time, I became very angry. And I can behave like I'm angry, or I look nice, but my heart was really angry, right? We can be very angry. And also there are a lot of resentment. I was resentful with a lot of things that did not happen or that happened. And it's all common to have these feelings, and there were a lot of blame and guilt feeling. Of course, I'm guilty that this is what I do. I treat cancer. How can I not save my own mom? I felt guilty. And there would be a certain stage of the time, withdrawal, isolation, and you felt hopeless. And I had one period of my life that I absolutely not want to talk to anybody. I isolated myself. If anyone tried to talk to me, and I was like, no, I don't feel like to talk to anybody. And I isolated myself. And of course, on top of everything, anxiety is something everyone would experience all the time or at one part of your life. And those are the common emotions everyone would experience. I experienced it myself, and everyone would experience. When you experience those emotions, don't feel bad. That's normal human emotions, and everyone would experience that. That's common, normal human emotions. And what I want to emphasize is that you feel what you feel. No one can tell you what you should feel. What you feel is what you feel. And I was angry and unhappy. I still clearly remember after I came back from China, I was really living in the hospital 24/7, taking care of my dad who had a major cancer surgery. And I came back exhausted, tired. But I also agreed to chair a national conference. So I had no time to grieve and feel sorry. So I immediately was chairing that conference. And after the conference, there was a small reception. And I did not want to go. And my friend was like, no, you have to go. And I told everyone, please don't ask me about my mom and my dad, otherwise I cannot go. So everyone promised, so I went. And after I came home, my husband was like, oh, wow, I cannot believe you're coping so well. You had a party, you went for a party. Right? Yeah. So my reaction was like, what do you mean? And he was like, aren't you supposed to feel sad, don't want to eat, and like sorry about your mom, about yourself? How can you can put yourself together and make a party? And I look at her, and I look at him. It's not her, it's him. I look at him, sorry about that. I look at him, I was like, interesting. What I feel is what I feel. I actually feel pretty numb right now. This is what I feel, and this is how I cope. And even you are my husband, even we are married, I don't think you have the right to tell me how I should feel right now. And often the time, we are very vulnerable with a diagnosis. You have your doctor, and you have your family, you have your loved ones, all your close friends. You should feel okay now, or you should feel better, or you should feel bad. No, you feel what you feel. No one tells you how you should feel. And this is a big lesson I learned when I go through the mental stress, that what I feel is what I feel. I had this lovely patient, she's 58, and so it was 6 months ago I saw her, and she came to me, and she's like, Dr. Yan, I'm not happy with my breast. I want to do a reconstruction. But everyone is telling me I'm vain, and I'm old, and how do I care? Why should I care about my breast? And that's exactly what I told her. I told her, no, what you feel is what you feel. No one should tell you how you should feel. And she was shocked. She looked at him and said, hey, Dr. Yan, I'm surprised you said that. I'm expecting you tell me that I should care about my life and my cancer. I should not care about my appearance. And what I told her was the same. No, you feel what you feel. If this appearance gives you so much stress and it's the #1 source of anxiety, we should take care of that. And she was like, oh, thank you for saying that. And also, by the way, 58 is not old. 58 is very young, actually. So of course, she went home, she felt supported, and she had her reconstruction. And I just saw her last week, and she came back. She was like, yeah, Dr. Yan, I don't know if you still remember, 6 months ago, you spent a lot of time talking about. I was like, yeah, let me tell you, I remember what I said. You feel what you feel. No one else can tell you how you should feel right now, this moment. How should you feel about your diagnosis? You feel what you feel, right? I just want to make sure we put our feet down there, and what I feel is what I feel. And because, it's not just a diagnosis. It's just not a treatment laid out for you. We are grieving. We are grieving of the loss we have. We are grieving the loss of health, the loss of control of ourselves. We are grieving the loss of our women's part. We are grieving that there are some friends who actually cannot deal with that. And we are grieving a lot. So it's actually a grieving process. So I see a lot of nodding here. This is exactly how I felt. When I was going through the mental stress, I lost a dear friend. And what she did was, she's actually an oncologist, she's a dear friend. But I felt comfortable. I did not share with a lot of people right after my mom passed away, but I shared with her. And her reaction, still today, I did not understand. Her reaction was like, what happened? What treatment did she get? What side effects did she have? And what happened? Maybe you should have done this, you should have done that. That's her reaction. That was absolutely wrong. And I stopped texting her back. I stopped talking to her because I cannot answer all those questions. And I was grieving, but she should not have told what I should have done, what I should go through, right? That's a very hard response for me to accept. So I truly want to emphasize here is what you feel is what you feel. Even it's your best friend, even it's your loved ones, and even it's your doctor, they cannot feel for you. And it is important to keep emphasize that you feel what you feel. And what you feel right now, this moment, is what you feel. And no one can dictate for you, and no one can tell how you should feel. And it's part of the illness of now. There's an illness of now. And you cannot argue with that. And all your lovely one, your family, your doctor cannot argue with that. What you feel is what you feel. So I just want to make sure, we truly accept that and understand that. But with that being said, I just want to emphasize that for breast cancer community, and we have way more resource today for support, and we have a large community. So back in 1990, the entire community of MBC in this country is about 100,000. But by January 1st, 2025, there will be about 170,000 people in the community. And when you see the graph on the right, the incidence is actually the same. The dotted gray line, black line is the incidence. We did not have more diagnosis, but the community is larger. Why? Because everyone lived longer. So I just want to make sure, everyone heard, yeah, right? Did I make everyone a little bit happier? Yeah, the black dotted line is the incidence. We do not have more cases each year, but the community keep expanding because everyone is living longer. So the community is expanding, and we have such a good support right now. And by looking around, you are not alone. And there are friends, and this is a community that when you look around, you're not alone. So I just want to make sure everyone is aware of that. And when I look at this number, I'm very proud that compared to 1975, the chance to die from breast cancer reduced by 58%. This is how much progress we made. And compared to 1975, out of 100,000, there will be about 48 deaths, and today it's only 27. And the most progress we made was actually from 2000 to 2019. So that's when we had all the targeted therapy, immune therapy, and a lot of new treatment options. And even just for MBC itself, the chance to die reduced by at least 29%. So we'll have a lot of medical treatments and progress later. And that's not my job today. I just want to focus on the mental health today. And also, the median survival for metastatic breast cancer significantly improved. So, that's how we live in a larger community, and we have more support. So coping, how do we cope? And I emphasized you feel what you feel, but there are still coping mechanisms that we can work on, and in that way we'll feel better. So the first advice I give to everybody would be take your time. You feel what you feel and take your time. don't be rushed that, oh, I should feel grateful now because I have treatment options. Oh, I should feel better now because I started my treatment. Take your time. And there are different coping stages, and different people will behave differently. You can stay on one stage longer, the other stage shorter, or you can come back and forth multiple times. The cycle, initially, everyone would experience denial. This is not true. I don't believe that, denial. And we can have the defense mechanism. Let's fight this and let's do it, right? And we can have the discarding part that, or we can adapt to it, or you have the internalization. So there are different stages, different cycles. You can stay at one stage for a long time, don't progress to the second stage. That's totally okay. Take your time, and it's common that you can be in denial back and forth, and you can actually feel you are defending yourself back and forth. And that's totally common and normal. So take your time. Don't rush your emotions, and don't rush the way you cope. And of course, the second advice I just want to put up there would be make sure you're comfortable with your medical team, and also consider clinical trials. And we are all human. Am I perfect? I'm not. I have patients fire me all the time. They don't like me. I will say, okay, I'm sorry, I did not do my best. I'm so sorry. It happens, right? If you don't have confidence in your medical team, we got to work that out. And we have second opinion, third opinion, and if you don't have the full confidence, how can you make it work? So you have to be very confident with your medical team. And it's not just your oncologist. You have to be comfortable with the front desk, and you have to be comfortable with the social worker. You have to be comfortable with your entire team. And that's how your coping can be better. And also, I want to emphasize clinical trials. The reason we improve the treatment so much is because millions of other women participate multiple clinical trials. And this is how we move the field forward. And that's exactly why I emphasize, if there is a clinical trials available, if you're a candidate, please consider it. I see quite a few of my patients nodding because they are all participating in clinical trials. Thank you for moving the field forward. If you search clinicaltrials.gov, and just for metastatic breast cancer, there are over 4,000 clinical trials nationwide. And even only in Washington state, we have over 350 studies. So there are a lot of clinical trials that we are trying to move the field forward. And of course, I had some patients was like, well, I do not want to be the guinea pig. You don't have to be the guinea pig to participate in clinical trial. There are observational clinical trials, and that can be very helpful too. So truly, I want everyone to consider that it's not you're only helping yourself, and imagine you are helping many other, I cannot say only women and men out there too. So, please consider the clinical trial. And often the time, I truly have patients telling me, okay, I'm participating in the clinical trial, I feel I'm contributing, I feel I'm helping, and actually it helped to cope my own stress that way, because you have that internal rewarding feeling that you feel you're helping, and then that makes you feel better. So not even to mention, we do have studies to show that those patients participate in clinical trials, they actually live longer, they actually do better, because you would have access to the newer technology, newer treatment options, not even to mention you will be so closely monitored by such a big team. It's no longer your medical oncologist, the research team, and there are a lot of monitoring mechanisms. So this is exactly why I advocate, if you are truly a candidate for clinical trials, please consider for your own benefits and also for many other folks out there. It's interesting that actually, not very commonly, our breast cancer medication was on New York Times. That was June 2022, and the invention of one medication actually can improve survival by almost 2 years. That was on New York Times, and I was very happy to see the headline. I was like, wow, okay, great. This is one of the progress we made. And this is one expanding options means prolonged survival. And with all the clinical trials, with the newer technologies, this is how the field is evolving. And this is how we are confident that we can make everyone live longer. So for that reason, the community is larger, and please participate in the clinical trial if you are a candidate. And the next advice would be support from others with similar diagnosis. And I actually have quite some patients, they call she's my cancer mentor, right? And I cannot emphasize enough that how important a mentor can be. You know, especially for the medical career, I cannot be here without all the mentoring me in the past whatever years. That, you know, when I was a PhD, I have my PhD mentor, and then I had my postdoc mentor, and I have all the mentor. The other one with similar experience, and they can help you, and they can help you cope better. So, you know, if you join in the support group or here with Susan Coleman, and if you actually can connect with someone who was a little bit ahead of you, willing to mentor you through the diagnosis and treatment, often the time I heard that can be very helpful. And also there are a lot of volunteering opportunities, and it works for me in the way that if I'm volunteering, I volunteer for multiple organizations, I felt I'm helping, I'm contributing, and that actually helped with my mental stress. And this is a not complete list, I copy and paste from the Department of Health from Washington State. And there are multiple organizations, and they provide support. So American Cancer Society, Cancer Lifetime, Cancer Pathways, and I was trained at Fred Hutch. Fred Hutch has wonderful support, and Hamilton Hill, and actually I emailed them last week to test for it. I have not received the email back, but I was testing for it. And also, you know, there are a lot of local organizations, and you know, if you are truly willing to volunteer or even participate in a program like that, just network and connect with others, and that often the time can be a very good coping mechanism. And what I want to bring up is there are quite a few small nonprofit organizations. You know, Susan Komen is nationwide. I'm grateful that it's coming back locally. It's no longer just nationwide. And I volunteer for Northwest Hope and Healing. And we actually have a fashion show each August. And I actually, we have a few models here sitting here today. And the Team Survivor Northwest is another nonprofit organization. They focus on fitness, exercise, and they do the Dragon Boat each year. That's fun, right? And another patient of mine, she's from far, and I heard from her that there is a Kathleen Sutton Fund, that if you live in certain county and if you need transportation, they actually provide transportation. So one patient of mine has been receiving sponsor from that. She has been a keynote speaker for the program, and she told me actually for the 5 years she was getting her cancer treatment, the fund she received after she put together was about $50,000 actually. So you know, those are all the local support, and those organizations are very active. So if you truly are willing and have the time and willing to work with those organizations, those are all great resources. And also seek out a social worker and counselor. This is very important because often the time we felt that, well, you know, I have my family, I can talk to my lovely ones. But often the time, what I heard is that it's very difficult to actually share your feelings with your lovely ones. Often the time, it's actually harder. And I had quite some patients share with me that they felt they were better heard by someone who had a similar diagnosis, not the lovely ones. And it's very common. And often the time, we ignored that our lovely ones, they may need coping more than the patients actually, right? Yeah, so you know, that's how sometimes we cannot put that burden on them because they may need more coping than us. And it is important to talk about the fears and concerns, even the treatment's going great. Everything is smooth, everything is working, but we still need to talk. It doesn't mean you don't have the fears, you don't have the concerns, right? So even the treatment is working, make sure you talk about the fears and concerns. You know, we do have the social workers, counselors, psychiatrists, or even the oncology team, that they can find more effective ways to cope and talk about the diagnosis and be open about it and share your feelings. So there are different mental health care specialists you can look up to. They are individual psychotherapies, and nowadays, and actually there are quite some virtual and online sessions. And for where I work, when I was going through a lot of mental stress, and I was offered a same-day counseling session and for free, and I really appreciate that. So make sure you take advantage of that. And of course, social worker is such a blessing resource we have, and especially oncology. So we have our dedicated social worker, and often the time, social worker would reach out. But if you felt you have concerns that were not heard, feel free to reach out to the social worker. And also they are psychologists and psychiatrists. We are blessed in the way that we have social workers sit next to my office, and the psychiatrists sit on the same floor. And they offer all the counseling and the coping mechanism, so make sure you use them. They are here for you. And you're not supposed to get your treatment, go home and cope yourself. And be open about what you feel, and if you really need help, there are psychotherapy, social worker, psychologists, and psychiatrists that can truly help you. And also, of course, when we have to be on medications, we have to be on medications. And this is where the palliative team and psychiatrist team can be helpful. I had this patient, and when I was talking to her, she told me, well, I was so depressed and anxious 20 years ago, and my psychiatrist started me on one of the antidepressants. I feel so much better. And I wish I started that earlier, right? We all had that experience. Don't be afraid when you need medication help to feel better. And so the upstream palliative team is truly very helpful in the way that back in 2012, at our ASCO annual meeting, and it was recommended to actually include palliative care to the standard oncology care. It has been more than 10 years that it's recommended that palliative team is part of the standard cancer care. And often the time, I have lots of patients, when I start to mention palliative team, and a very common reaction would be, Dr. Yan, are you giving up on me? Is this hospice? It's absolutely not. And the education was palliative team is to focus on managing of the symptoms to help you feel better and actually improve the oncology care. And it's supposed to improve quality of life, not only for the patients and also for the families too. So that is exactly that. We will have a palliative team's palliative care session this afternoon by Dr. Lee, that she will give more introductions. But often the time, I'm grateful when my patient asks me, Dr. Yan, can I see palliative team? Yes, of course. They are a wonderful resource that I think we are not used as much as we should be. And there are a lot of studies to show that early adoption of palliative team manage symptoms better, improve quality of life, and understand your prognosis, and improve the outcomes, improve the mood, and improve the survival, and they are a great resource for us to use. So, if you don't feel you like it, you don't have to, but I just want to remind everyone the resource is there, and they are good to provide medications and a lot of other coping mechanisms too to help you feel better. And of course, what they are focused on would be managing the symptoms and also help the coping, and also they serve as a bridge between the patient and the oncologist. Because often the time I did hear that Dr. Yan is all about make me alive, treat me. Sometimes she doesn't hear me about my fatigue and my quality of life. I'm sorry I do hear it, but also part of me is I really want to make you live. And that's where I'm trained, that's where I'm from, right? Sometimes I'm like, yeah, I heard you, but this treatment can make you live longer. So this is when sometimes the palliative team can be the bridge and wake me up, say, hey, listen, let's talk about it. So, this is often the time that I heard it even better when I heard from different sources, right? We understand and we help each other better. And of course, the adoption of palliative team has been increasing every year, and it's very interesting. I think this is a minor aspect for me, but maybe important for everyone here, that adopting the palliative team and actually reduce the cost of the patients too. often the time, when we are not aware of the resource, and there can be a lot of unnecessary intervention and cost, it actually can reduce the cost. Yeah, and that's a very interesting data for me to read. And everyone knows me, I advocate exercise, 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 right? Exercise is actually very important, and it actually improves the coping mechanism. There are multiple studies. And a very well-known study would be PAM study. It's actually a randomized study. We randomize about 100 patients to good exercise, a supervised aerobic and strength training 2 hours a week, and also they have to do the power walking 2 hours a week, so almost 4 hours a week, compared to, well, you do whatever you need. And exercise improve cognitive functioning, physical fitness, fatigue, quality of life, depression. Powerful, right? Yeah, so this is often the time, and I had some patient was like, well, I truly want to exercise, but I'm tired. Well, I'm here for chemo. Shouldn't I just go home and lay in the bed and rest? So actually, exercise is a very good coping mechanism to make you feel better. I'm a strong believer of exercise. If I kind of get lousy with my exercise for a couple of weeks, I truly felt worse and more fatigued. So, I want to emphasize that, it's important to incorporate exercise as part of your coping mechanism. And not even to mention, it even can help to reduce neuropathy. There were studies to cancer patients and specifically look into exercise when they were receiving chemotherapy-causing neuropathy. And actually, the exercise can reduce neuropathy symptoms. Interesting, right? So, make sure you heard the data. And also, everyone is asking me, what exercise? And any exercise make you happy and make you willing to do it every day. And there are another meta-analysis only on yoga. And it was actually 24 studies, including more than 2,000 patients. Even yoga actually can improve quality of life, reduce fatigue, help with your sleep. Often the time when a patient comes to me and says, hey, Dr. Yan, can I sleep? And my answer is always exercise, right? Yeah, so, truly exercise has a lot of benefits. Not even to mention after exercise, we're happy, right? Your brain is making all the epinephrine, endorphin make you happy. So make sure you incorporate exercise. And also, there are studies to show that exercise potentially may improve survival. And this is really intensive exercise. Engaging 1 hour per day of moderate exercise reduce actually death by 23%. Impressive, right? I'm not saying exercise can treat all the cancers, but when you are receiving your treatment, exercise truly can improve your quality of life, make you willing to get more treatments, and subsequently improve survival. So I just want to make sure, human is built to be active, not sit there laying in the bed. So make sure if you are willing and the weather is getting better, exercise every day. And I really promise everybody, this is the only time I promise everybody, after you do your routine exercise, you feel better. And also, there are a lot of European studies and look into the MBC patients, specifically on physical exercise program. And it's interesting that even we emphasize the importance of exercise, but there are folks still cannot do exercise. The reason would be, I feel too tired, thanks to the chemotherapy, or they feel weak. And the most exercise the patient would be interested would be walking or exercise in a gym. So very common, right? If you like pickleball is a big thing here. That's nothing wrong with that. If you love walking, that's nothing wrong with that. Any exercise make you willing to do every day, that would be for you. And also, I can never emphasize enough that get peace of your mind. Often the time we are anxious about what's next, what am I going to do if one day I'm not doing well. So the peace of mind would be the advanced directives and the post form. And I just filled out a post form yesterday in a way that I explain to everyone, it's not fair when it's a time that you ask your loved ones or even your friend to make decision for you. And it will be a lot of pressure on that person. So, if you can think about that and we can actually have the advanced directives or post form filled out earlier than later, that's often the time very helpful. And the last but not the least would be, I recommend everyone focus on what brings you the most meaningful and joy. And I have my own bucket list. I hope everyone has a bucket list. I hope everyone does. And focus on the things that you are happy and make you feel meaningful. So this is a very interesting data. And reconstruction. You would imagine, it's MBC. Why do you want to talk about reconstruction? But it is interesting that when we look into the National Cancer Database for patients with de novo metastatic, and actually the chance to have reconstruction actually significantly increased by year. It was only 5% in 2004 and tripled in 14.3% in 2013. Because now everyone lives longer. And what's wrong? I want to look nice and I just care about my appearance. And of course, younger patients tend to have more reconstruction and hormone receptor positive, or it's low grade. And it's not crazy. If this is something that you really truly make you feel better, and it's not crazy and wrong to talk about it, I'm not recommending that to everybody. But there were 14.3% of the patients actually went through reconstruction. They did just fine. So this is an example. If your appearance is very high top on your bucket list, and you should investigate and look into it and talk about it, don't be scared and don't be worried that you are being judged and it's crazy to talk about that. And truly, I always like to share Phil. Phil is not an MBC patient. He's a stage 4 colon cancer patient. He's our patient. And Phil, he lives in Vashon Island, and his bucket list was that he want to walk the Camino. A Camino is on my bucket list too, by the way. I just never had the time to do it. So, and he was telling everybody that this is my bucket list. I really want to do it. So his oncologist worked with him, who is a dear colleague of mine too. His name is Phil too, by the way. So 2 Phils. So 2 Phils work together. And what Phil does is after each chemotherapy, and he went home and he had a path in his backyard that he walked and practiced and trained himself every day. And his story was so famous that there were a lot of volunteers would just go and walk with him. And finally, he did so well that his oncologist was willing to give him breaks that he actually made it. So it was a documentary, and I have the DVD. So, I went to Spain last year, and I ran into 2 sisters in the airport, and they both were like, oh, we just walked the Camino. I was like, oh my God, I'm so jealous. I need to walk that. I have not done that. They're like, well, it's rough work, and you will have blisters. It's hard work. But can you imagine, Phil, a stage 4 cancer patient, that's on her bucket list, and she made it, and he felt good about that. So this is exactly that, I want to emphasize that regardless you have the MBC or not, have your bucket list and make it work and do it today. For Phil, he was practicing and trained himself every day, and he made it. We were very proud of him, and he was very proud of himself. So, I give quite some informations, but the key message I want to deliver today would be we need to prioritize mental health. When we do not have the mental health, it's harder for us to cope, to tolerate the treatment. And you're not alone. Remember, we have a large community, you have a lot of support, and keep in mind you are surrounded by resource and support. And I keep emphasizing that you feel what you feel. No one can tell you how you should feel. You feel what you feel. And also, don't be shy, ask for help. If you're stressed, if you're angry, if you're depressed, then tell people and ask for help. Because together we'll be stronger. Yeah, so I'm open to questions. Anyone has questions for me, or you are too scared to ask me questions? Are we on time? I did not look at the time. Okay, great. Okay. Yes. Um, the only scenario would be if it's not the right medication for you. And I don't see any reason you cannot be on antidepressant if you truly need it. But I'm honest that typically I rely on our palliative team and psychiatrists, make sure they give the consultation and make sure it's the right diagnosis. It could be, what if it's not depression, it's bipolar, it's other disorders, and that could be other medications, right? And for bipolar, and antidepressant actually can cause manic disorder. So this is exactly why we want to have the right diagnosis and make sure it's the right medication. But if it's truly anxiety, depression, and I don't see any reason we should not consider antidepressant. Yes. Okay. Absolutely, why not? Right? Yeah, why not? Why? Tell me why you cannot do scuba diving. Okay. Oh, interesting. We can look into that. Yeah, I don't swim, but I still enjoy diving. I don't do that every year, but every time when I visit places, I can potentially do some scuba diving. It's amazing. It's such an amazing experience. You should absolutely experience that, especially if it's on your bucket list, and do it today. Start to work on it today. All right, yeah, I will be around, and if anyone has questions, I will be around, and I thank you, everyone, for your attention, and hopefully you enjoy the rest of the program today. Thank you, everyone.
Thank you so much. So without further ado, I would like to introduce our friend from the Hutch and from UW to talk health equity and disparities here in the Pacific Northwest. I'm pleased to introduce Dr. Linden.
All right. Thank you very much. Thanks for your attention. I'm sorry to stand between you and lunch. So this is a topic very near and dear to me, but not the usual topic that I speak on. There are disparities in the world, in the United States and here locally, and I think this is really it's known to everybody, and medicine is in the context of the broader problem. This is historic and substantial, and there are structural issues. And I think we have done poorly, we can do better, and we will do better. Let's see. Okay, we'll just try this one. Yeah. Okay. So I am an unusual person in our system. I'm paid by the University of Washington, and I practice at the Hutch campus mostly, but I also have worked at Harborview since I came here, which was a long time ago, as a fellow. And so I've had a different experience, and I've remained there as faculty, and I'm there one afternoon a week. So I've had a chance to work with some fantastic people, and I'm going to share some of that with you. I've also been asked to chair our Health Equity Steering Committee, and I'm going to share some of that work with you as well, and some of the specifics. So, the world is not fair, and we have many problems. These are just a couple headlines from the Washington Post, and they're about that there's new therapies out there, like Dr. Yan spoke about, that have really improved things, but actually they're not accessible to everyone, and they haven't been tested in everyone, which makes it difficult to know how to disseminate that evidence. And the piece about many patients don't survive end-stage poverty, that's the problem. One of the main reasons for healthcare disparities is just the structural, societal differences between poor and middle class and the high-end populations. And the truth of it is, for some people, really healthcare is the least of their issues. They need a roof over their head, or they have other major needs. And so the piece that I've referenced up here is about that the resident spends all their time really just getting placement for the patient to live so they won't get readmitted, and to try to help find support for people. There are just many problems in the world, and cancer is one of them, but we have to lay it on top of these other issues. So in terms of the burden in the world, we are actually quite privileged here. We're in a higher income country, and what you can see is the incidence rate is the pink, and the brick colored is the mortality rate. So in the higher income countries, people live a lot longer with their tumors. We get them earlier. We do much better with the care. And in other areas of the world, basically people present late stage and we don't have as many options for them. So it's really striking if you think about the difference between here and Europe and Australia and other countries where there just there aren't resources. So one of my comments here is that it's horridly unethical to go to Africa and screen when you can't do anything about it. We've just got the latest news about screening younger people, which I think is terrific. But there are countries where none of that's happening. So Harborview, we have a clinic there that we see people with multiple types of blood disorders and cancer. Most people are from King County, but there are people who move here for care. We see a lot of immigrants who are on the Pacific Rim. And so while the top language at both institutions I work at is Spanish, at Harborview we have Amharic, Somali, Vietnamese, and Cantonese speaking patients, and the population is only half white. We really see a diverse group of people, but we are the safety net. We see common malignancies and we see rare malignancies, and we see people who don't have any coverage whatsoever. So they come to Harborview and we get them coverage, and then we can care for them. But doing that is difficult, and so there's a program at Harborview that was developed 30 years ago, and this was for cultural mediation and patient navigation for refugees and immigrants in a complex health system. And this actually was developed initially to really to help support people across the spectrum of care. And it was developed initially for maternal fetal health, for asthma, and for TB. And these are very treatable, fixable issues. I think most people are aware that there are huge disparities in maternal fetal health. And so the idea is prevent people from needing to come to the ER and help them really get the care they need. So this is, bridging a huge gap from people who may have been living in a refugee camp before coming here. And that is what the Harborview International Clinic is all about. And they do a mix of things where there's interpretation, but there's a continuity of interpretation. And they'll reach out literally to your home so they can follow up and make sure that you're able to implement whatever is needed, and help you get English as a second language classes, and help your kids get education and your family get jobs. There's also an education piece to it, which is called EthnoMed, an award-winning American Library Award-winning program that really is part of UW, but it's sort of its own subset where there's academic pieces, but also really cultural pieces and ways to explain things. When you're feeling like you don't know how to explain something, you can look it up on EthnoMed and help a patient understand, for example, why we would recommend colon cancer screening, which might be a very foreign topic to people. So the program, the Community House Calls program, is designed as a bridge between the patient and the institution. And so, you know, there's a lot of distance between providers and patients sometimes. There's the family, there's the community, there's the institutional barriers. There are people who don't understand why we ask for informed consent to do a procedure, because in the country they're from, you didn't ask that question. So it's to bridge that gap, and the role of the cross-cultural mediator is to fix it. So they might, for example, give me feedback and say, I'm not translating that. I can't believe you said that. That's not culturally appropriate. This is what I want to translate. I think this is what you meant. And these are really important pieces, and because they're providing a continuity, we can really factor it into the whole, the patient experience with the entire system. And this has been a really successful program because honestly, it saves money if you do things right. That if, you know, again, patients don't end up in the emergency room with a treatable problem if they understand actually how to use their asthma inhaler, for example. And so they can provide that extra piece. But I want to be clear that the role it's to be 1 foot in their community and 1 foot in the institution and helping us make our institution better and more culturally appropriate. So they provide the cross-cultural mediation. They do also provide a continuity of translation, and they provide education and documentation. So examples of things they've helped me with are, you know, get the slides from another country here. And help a patient, for example, get their spouse here, get a visa for their spouse, work through you know, a lot of red tape in both our country and the country that the patient's from, and they've really performed many small miracles to build trust. And I think trust is a huge issue, especially if you have a history of you know, being neglected by the healthcare system. So we have a community advisory board. That's how you do this kind of work. You have to get feedback from the appropriate community. You can't just do what you think is best. You have to engage and listen, and I think listening is the biggest piece. But what the community advisory board has asked them to do, and this is how I got involved, is to do something about cancer, because they viewed that as a huge problem in their community. But also mental health, diabetes, accessing care through the Affordable Care Act, which makes the blue states a much nicer place to live for people, where you can actually get a lot more access to health care, and also figuring out how to access information on the web. And, you know, one of the huge perks really from telemedicine is that we now have translators readily available on the web. And so you can always get a face of a person, not just the phone. I hope for the rest of my life I never have to do a phone interpreted visit. I always feel like that's just not a good feeling, and provides sort of zero clarity and little trust. So what we've learned from the Community House Calls program is that when you build community involvement at the start and you maintain it, that's a key feature. You can't just sort of take the ball and run with it. You have to keep interacting. And then you have to have people who are really willing to do this, and be a champion for the patient within the institution and as well as in the community. You have to provide a reasonable wage for people when they're doing hard work, and you have to provide good supervision. There are times where we've had to sort of say, you have to allocate the resources. I mean, sometimes you can't provide everything for every patient. And if one patient sort of continues to make poor choices for themselves and use the resources, sometimes you have to move on to help more people. But that is a very hard thing for anybody to do on their own, so you need supervision. And then you have to provide ongoing training and support because, of course, things change. That's the fun part of medicine, and balance the service with the cultural mediation. The cross-cultural mediators do make field trips. The rule is kind of one. So if they wanted to go to a different institution and get an opinion, actually the cross-cultural mediator would go with them. But if they were to then stay at the other institution, the cross-cultural mediator would not. And you also have to collect data because you have to understand the problem and prove the utility. So Another thing that has happened because of, I mean, I do see neglected disease everywhere I practice, but I see more of it at our county hospital. And so I think there's a cycle for people with neglected disease. And, Dr. Yan talked about the denial issue, but I think within there's actually often a fear of financial toxicity. The financial toxicity of cancer is very real, and yet there's also just a fear of, well, I don't think everything's going to be covered, or I don't want my family to be in debt, or I want to just keep doing what I'm doing, and if I stop and get treatment, then we won't have a roof over our heads, or I won't be able to, care for my daughter's kids while she goes to work. So I think that there's a cycle of fear, and that can really spiral, and you can end up with a neglected tumor. But that doesn't mean we can't treat you once it's neglected. And one of the more satisfying things for me as an oncologist is that, I've been able to help people who have neglected their tumor for quite a long time, and we still have the same therapeutics, and they still work. Okay, so at Harborview, we provide screening for charity, and we explain to patients clearly what's going to happen, so we can predict whether or not they're going to get coverage. There can be a problem where the middle class is squeezed, because if you have too much money, you don't qualify for Medicaid. But we can explain it and figure it out, and usually get you pending coverage, which means you will get charity care. But what really happens is you get the biopsy and you get the staging, and then you get a plan, a treatment plan, and you do get on Medicaid. And we're able to predict that for people, so they understand that it's likely to be that everything's covered, including the reconstruction. We provide social work, case management, and really patient financial advocacy. There is an international clinic as well as multiple primary care clinics. We have a pharmacist on site, and that is the PharmD is actually managing the copay assistance for patients and advocating for coverage. So it's a really nice service. And we also have palliative care on site, and our palliative care doc also makes home visits with a whole team, has a homeless team as well, and we do have a respite facility at Harborview for people who don't have housing to get off the streets. We also provide in-person translation or video translation with our cross-cultural mediators in person. And the other thing that we've been able to do is, we still are really part of the University at Harborview, so we can screen at just the same level that we screen down the street with advanced molecular diagnostics and make a sophisticated medical diagnosis. So what we've been able to do, and this has been part of my job for quite a long time, is to really integrate clinical trials into the care of vulnerable patients. In general, the way we do that is that we refer patients to the Hutch for studies, but we have a study that gave patients with HIV-associated Kaposi sarcoma immune therapy. So we've had a long-standing HIV clinic with a great team and very culturally appropriate care, and so we actually have a number of patients who've opted to not go on treatment right away for HIV. And that's why we see a lot of Kaposi sarcoma, and that's why we could do that kind of trial. So we did open that up actually at on-site at Harborview. But we've also come on-site to interview patients and participate in the HiCOR financial toxicity trials that I'll tell you about later. And we've been able to get medical genetic testing for patients. BRCA is a misnomer. It's not just breast and ovarian, it's prostate and pancreatic as well. So we have a study that patients have been able to enroll in to get germline testing, and that can also really matter for their subsequent treatment. And it's a bit of a myth that that mutation is common in any one ethnic group. I have diagnosed many people from East Africa with that mutation. I have an interest in molecular imaging, and we've had several clinical trials, and that's a nice trial for patients to participate in because There's no randomization. You're just getting an image, and then you're getting the care that you were going to get whether or not you got that imaging study done. So that's been very appealing to people, and I think a way to build trust. Perhaps our best improvement that we're offering here in terms of social interventions and on a trial is Kemi Dahl's endometrial cancer study, the sister study. And, you know, one of the reasons that we have disparities is that everybody doesn't have support. Everybody doesn't have a friend or a family member or a coworker who can not just help them get to the clinic, but help them believe in the clinic and help them feel supported. And because Black people have been mistreated historically and famously, and that's the Tuskegee experience is well remembered by people in our community today. So people, if you don't trust that you're going to get good care, maybe you wouldn't proceed with care. And that's what the sister study is all about, is really providing that support for women with endometrial cancer. Huge disparities for this group. And so we're thrilled that PCORI funded that study. So what are we going to do? Well, what we're going to do is try to continue this. We helped set up Children's Hospital with a cross-cultural mediator program, different than the Harborview program, but similar and a similar style. And actually, we launched the Hutch patient navigation program, really based on the expertise from the CCM program. But it's different. It doesn't involve house calls. It has a few more limits, but it's still a similar program to remove barriers to care. What we're hoping to do at Harborview is, when I was first there, we had an infusion suite on site. That's now migrated to UW, which is a real hassle for the patient. We're hoping to, there's a pretty good plan in place to bring the infusion suite back to Harborview to provide a medical home for patients. And we're opening selected studies, and we're building bridges between the UW and the Hutch to make it a tighter collaboration. Okay, so moving to the Hutch side. HICOR is the Hutchinson Institute for Cancer Outcomes Research. And what their goal is to understand the quality of care across the state. It's a database that looks at who's paying for care and where the care is gotten. And of course, as you might imagine, academic centers and centers in major cities provide different levels of care than is available in a rural setting. And so this is publicly available material. You can download the report on the web, and you can find out that we also spend a lot more money on healthcare, and perhaps we're less efficient. But I think the key findings from Scott Ramsey and Veena Shankaran in multiple publications, and Harborview patients did participate in some of this, is just that the financial toxicity of cancer causes significant morbidity and mortality. And I think, for this room, I'm sure you know that already. But we have to prove that in order to do something about it. But when Dr. Yan was talking about stress, money is what stresses a lot of people out. The impossible question that I can't answer is, sort of how to meet out your resources. And figure out, well, what's the optimal time for me to stop working? What's the optimal time for me to go on the trip I want to go on? These are tough things, and I think that the financial toxicity of cancer in America is horrid and unacceptable, and it's something we have to do something about. So we did some research with HICOR, and we looked at metastatic breast cancer across the state of Washington for a decade, and we identified 1,000 patients who had metastatic breast cancer, and we looked at whether or not a tissue biopsy was done. It wasn't done 50% of the time. That's terrible. What we learn, the catchy phrase is tissue is the issue if cancer is the answer. So not getting tissue is terrible. You need to know whether or not the estrogen receptor is there, whether or not the HER2 pathway is active, and other molecular targets that are now relevant for many drugs. And most importantly, you need to know that they actually have metastatic cancer. So there are many people being treated in the state of Washington with the assumption of metastatic cancer. Now, it's a pretty high number, and the question is why? And there are many, many answers, including the diversity and access issue. But one of the reasons is just that sampling bone is actually very difficult. And you need to know how to do it. You need to know how to process the tissue. And all too frequently, we find out that you sample the bone and you get healing bone. You don't actually get a tissue diagnosis. So we also have developed estrogen receptor imaging, which could provide a virtual diagnosis for patients. And I'll just give you an example here of a patient who we saw, really thinking she actually came here for reconstruction because the plastic surgeon in her community had retired. So she wanted the comprehensive care, and when we did the surgery, we found a surprising number of lymph nodes were positive, and then we looked in her body, and you can see the spine has multiple sites of what are likely metastatic spread. And so then we did a estrogen receptor scan, which is out here on the right, and you can see that all those sites, in the spine and in the hips there, are actually much brighter by this scan. And so that tells you virtually that she actually does have metastatic breast cancer. But tissue is the issue, so we biopsied the bone marrow and the spine and the other side, since she does have it on both sides, and we just got healing bone. So this was very important for her because then we really did know what she had, and I'm not surprised she had estrogen receptor positive breast cancer. That's what the primary was. That's what we usually find. But it is entirely possible. She could have had myeloma or some other disease, and we need to know what's going on. She had a great response to standard therapy and has done well. But we did go back, actually, and process the bone more with molecular testing because we're getting better at that. And when you amplify up the normal bone, we were able to find a signature of her tumor. So I think there are ways we can get over this disparity, and that is one of our goals, is to try to improve diagnosis and precision medicine for everyone. And for the Comprehensive Cancer Center, the catchment area is the state of Washington, so we are trying. Okay, so the equity program at the Hutch, we had a task force, and now we have a more of a program. And as you might imagine, we're hoping to impact disparities in the state and impact the experience for patients and their families. We think this is an equity issue, but what's hard is that we have to deal with a system that has all the structural barriers to care. So we're trying to look at policy issues, we're trying to look at the culture, and we're trying to actually look at the laws in order to leverage them to allow patients access to two things: better care and access to clinical trials. Because, of course, you can't go on the clinical trial if you don't have access to care. So we have a steering committee and a large group with members from many different places within the institution and within the community. I am on that steering committee, as are several of my good friends, but this is a real commitment by the institution to make a change. And the idea is to really look at things, find out where the gaps are, and try to do something about it. I think actually the Hutch has a major ivory tower reputation, and we have to fix that. And so part of why I'm here speaking is just to say, we're trying to change, and we're taking this very seriously. And we're trying to help across the state. We have a history of programs in Yakima, and we have an office now in Spokane, and we have a site on the peninsula. So we're really trying to make sure we can improve the quality of care for everyone across the state, and also try to improve access to different trials. And there are all kinds of trials one can do. I think we all think of the standard clinical trial as you're going to try a new thing. You're going to see if it's safe. That's phase 1. You're going to see if it has promise. That's phase 2. And in phase 3, you're going to agree to be randomized against the current standard of care to something new. That's phase 3 is always the hardest thing to talk to people about, because they think, they just want what's best. And accepting randomization, I think, is a particularly tough thing. But we're not going to improve the denominator of who participates in these trials if we don't get better access. The other creative thing we've done with clinical trials is to actually think about how we can study things kind of without really putting any patient at risk. We can observe things, or we this is one thing that HiCore is doing right now, is we give everybody a device, like essentially a Fitbit, and we follow what your vital signs are. And we notice when they're not looking good, and I don't mean like horrible, I mean just your heart rate's just a lot higher than it was. That's a sign that maybe we need to talk to you and check in with you. So I think that's a pretty cool study, because there's kind of no risk, no harm. You might just get over-monitored. And we're looking at, there are ways to creatively think about this so that everybody has access to trials, and you have access to trials that might appeal to you and might actually make a difference for you. So the priorities are to champion the health equity goals and define some metrics so that we can actually do something and make a difference. I am pretty tired of just talking about it. So I am cracking the whip at that we're going to make a difference, and we have agreements that we're going to make some changes so that we can make a difference. I think the institution is very open to this, and I'll try to explain to you why. But we need to try to figure out where the gaps are and where the system is inequitable and how we can change that. Because again, we're part of a bigger society, so it's a little hard we can't change society entirely. But we can work on it, we can talk about it, and we can collect data and tell you if we've gotten any better. So this cuts across the patient experience, community engagement, and research, and the goal is to actually improve things. So what are we doing? Well, we're listening. I think that's very important, and we're identifying resources for uncovered costs, because I really do think the heart of disparities is often financial. We're tracking data, and we're making consent forms accessible in multiple languages out of the box, so that way you don't have to wait. Because the more delay you create for people, the more anxiety they have, and the worse their outcomes are. And we're navigating for patients, we're navigating for people in clinical trials, and we're trying to make sure that the patient experience is improved. What we've learned is that there are people who are in this middle silo where they have insurance, but it's not really covering everything. Maybe it's a husband and wife and they own their own business and they have 3 employees, them and their brother. And so they went skinny on the insurance, and now, they have all these copays, and they're going to break the business if anybody gets sick. We know that access to care is key and results in improvement. The Otis Brawley comment is, it's not about if you're black or white, it's about whether you live in Massachusetts or Mississippi. And if you live in Seattle, Washington, your care should be pretty good. Financial counseling is also an effective tool. That's another thing that patients really appreciate. They're actually, if you have to declare bankruptcy, there's some timing on that of when's a good time to do it. I know that sounds painful, but there really is good advice for people. And part of the HiCore studies have involved offering patient financial counseling to people actually individually, because that's usually private information that people aren't excited to share. So the New York Times covered this financial crisis beautifully it's an interactive opinion video, and cancer is not the only topic covered. But basically, there are gaps for people to get access to novel targeted agents. And, it's this game we play where we have to first ask whether we can have prior authorization, and then we have to hear that it's covered, but then what's the copay? Is there copay existence? And it's just a little odyssey that you have to go on in order to actually get the care. And if you change jobs or move or something else happens, you have to renew that whole process annually. And the video is really a tearjerker to show you how challenging this is for people and the losses that they've experienced. So really, actually, there are all these laws now that are mandating us to do better. So we have a comprehensive grant, your tax dollars, and we are supposed to include women, minorities, and individuals across the lifespan. There's a NIH rule that says women and members of minority groups and their subpopulations must all be included in NIH-supported clinical projects. Washington State just passed a law requiring clinical trials to adopt a policy of recruiting participation from underserved areas in 2000, and that was just last year. And the FDA has also a law that says you've got to do it. You've got to improve the diversity of trials, who participates in trials, because how are we supposed to recommend something if you've only got this tiny, narrow group? Now, I know that's why, I know why we do this. You know, we have to have people not have a reaction to the drug in order for the drug to be declared safe. But there's a way that you can also improve access to a variety of populations, which is what the FDA is saying we have to do. And so that's really why we're working on this now, is we know we have to do better, and really we're mandated to do better. So what has gotten better? I don't mean this to be an entirely depressing talk. We have a cure for sickle cell anemia. I mean, when I was a medical student, we all learned what the molecular signature was, and it was pie in the sky that we'd ever be able to fix it. Well, we can fix it. That's pretty good. We also know that some people run low white counts, and that's actually a gene, and that's called Duffy, and people are Duffy null, and it doesn't mean anything. They're very safe, and they can safely get drugs, despite having a abnormally low white count. It's not that low, and it's very safe. But we can also explain it to people. We also know that kidney function is not influenced by race. You know, so the disparities in care have really included people not getting transplants and dialysis based on a ridiculous measurement strategy. That's, I think, been fixed. I also would like to point out that even though these trials get done with, for lack of a better word, cherry-picked patients, those advances are available to everyone. And I think, as Dr. Yan went over, we've made a huge strides in what we can do for patients, especially for HER2-positive patients, and especially for molecularly targeted agents. So things are good. And where are we going to go? Well, I think that we are going to get over it and help people with the barriers that they have to get on a clinical trial. I think medical oncologists kind of hit things a little too hard with a hammer, and we're getting better at weighing the toxicity of drugs and the benefit, and having, because if you have an agent that is molecularly precise, you shouldn't have to give an overdose of it in order to be effective. I think we're getting better at this. I still think it's a weakness in medical oncology that we do treat people more harshly perhaps than we need to, but this is something that we have a history of working on at the Hutch with sort of low-dose metronomic regimens. But I think in the world of precision medicine, we're going to get better and better about making therapy safer. And I also think the big thing we have to do is kind of do some real-world studies where we include a broader range of patients in order to get data about a broader range of patients, so that patients can feel safer getting care from us when they can truly say, somebody like me got the care that you're recommending. And with that, I thank you, and I'm happy to take any questions. Yeah, so there's something called AEM, Alien Emergency Medicaid, and that is something. So if you, let's say you've been working in this country as a you know, on a farm, picking fruit, and you know we have a lot of that in this state, right? I mean, this is a fantastic state for produce. So you'll be covered by AEM, and you don't have to have that, but it's tricky because the actuality of the law is, if you have a brother in some other country and they are diagnosed and then they come visit you, but they're not visiting you, they're here as a medical tourist, we're supposed to say no. It's awkward for me. We generally say no. That's what we're told to do. That's sort of the way it's supposed to be. But I guess where I'm fudging this is, you know, so your brother comes to visit you and you don't talk about the biopsy in the other country and you say that this lump just appeared, your brother's going to get AEM. Mm-hmm. Right. Oh, no. No. Oh, no. No, I have patients like this. This is a horrible thing because then can you work here? We're not solving that. I'm just solving the care. So that is a bigger problem. But that's an example of something our CCMs have really helped with, is to figure out the red tape and figure out what you have to do. And, you know, and then they tell me what I have to write in the letter. But these are very tricky things. And what you're talking about is just sort of, you know, access to employment, different than access to medicine. Mm-hmm. Yeah. Oh. Right. Oh yeah, yeah. No, these are really tough things, and you know we've had patients who get denied because you know they didn't see their primary care physician for their renewal. You know, they're like these silly little things that happen, and so this is where these are processes that you just have to keep working on. So, I mean, I think that truthfully, you know, what all of us who do this know is, you know, persistence is what gets you somewhere. And you just have to keep asking. And this is why you're helping her, is because it's impossible to do on your own. It's really, I mean, I think, you know, I think that's part of the anxiety and the stress that Dr. Yan was talking about is if you don't have a supportive friend or community, it's really hard to get through all this. But you know, I would for the green card questions, I would reach out to a social worker wherever she's getting care. And this is a common question that we're asked. And the truth of it is, if we help support people, we improve their outcomes. You know, for all these things, right? Yeah, yeah, that's tricky.
I listen to this and I hear it, and we all know the battle that we fight with this disease. And I am a 20-year, 5-time survivor. But so much of that time and the anxiety that comes with that is the battle of fighting the systemic racism that exists. You know,
Mm-hmm.
I don't have a clue. Part of it is what she's probably dealing with, you know, but don't have a clue of how to overcome that, number one. Number two, not being accused of playing the race card all the time. And a good example, this morning, I happened to read that Nabisco, who makes child formula, in this country, they don't put sugar in it. In third world countries, the FDA has found that they put sugar in the baby formula. Why? You know, and so the distrust that exists is so real.
Yeah.
You know, because it's not just that study.
Right.
It's other
Oh no, it's everywhere.
on people of color.
Right. Yeah. No, this is we have a huge problem in this country.
So I'm listening to you talk about those new laws and all. People of color don't know about these laws.
Right. Well, I think what they need, the truth of it is, we don't just need a law. We have to just change. Okay. We have to build trust. We have to earn trust, and then people will know. Because really, the law is like, so what? You know, everybody breaks a lot of laws all the time.
Those who know the laws, if I go see my oncologist, she's not going to say to me, oh, there was a law that says you should be getting this, thus, and the other.
Right.
You know, and so it makes that battle so hard, so frustrating, so tiring, until it just becomes unbelievable.
Yeah, this is very hard talk for me to give because it is unbelievable. It's just, you know, come on. I mean, you know, if you have this history, what have you done about it? You know, I mean, so I think change is difficult, but I think the reason that I think those laws are important is the institution's like, oh, wait a second, they could sue me. Okay? You know, and there's a lawsuit at Cedars-Sinai over, you know, they have a 2-track system where if you're in the VIP club, and like the word VIP is like literally written on your chart, you get a certain level of care, and if you're in the other group, you get a different level. And so there's a woman who died as a complication of childbirth, you know, which is really unacceptable in this country right now. And her husband sued not just over her death, but over the pattern. Okay? And he's killing him. And I'm very upset just to read about it because it's mortifying that she got that terrible care. But that is what we've accomplished, is that they are going to really pay for it, and they're going to have to change. Somebody's going to watch them to make sure that they change the system. And this is happening, I think there are a couple more famous cases in New York as well. The Cedars-Sinai sort of, it just kind of shocked me because I just know them a little too much. But, these are the changes that have to happen, and the institution has to be sanctioned for bad behavior. And then it'll change. But yes, nobody should have to die for that. That's ridiculous. We all know that, if you're in a rural area and you have a bleeding complication of pregnancy, like, it could go bad. But if you're in a major city, you should be treated right. But the fact is that poorer people get worse care. And right. Oh, no, I know. You're right. No, exactly. Exactly. But if she had been on the VIP list at that hospital because she was a famous actress, might have been different. But, Serena Williams it's Serena, I think, who had the PE during pregnancy. We've got problems still, right? Pregnancy is a high-risk condition, but we shouldn't be making mistakes with it. Yeah. No, I agree with you. It's not just money. It's pure racism, and we have a problem. So we got to earn back the trust by doing it right, and by doing things like, we made a huge effort to fix sickle cell. It's, you can be white and have sickle cell anemia. It's just rare. But, we went after a disease that was known to be a black problem. And I think, we have to do things like that, and we're now going to have to offer it to people and get them through it and fix a bunch of people for people to trust the system. And I think the mistrust it's earned. That's a terrible thing. Mm-hmm. Native Americans are, another group that has been treated horribly. And so there are Native American hospitals. The Alaska Native Hospital has a special program. Yeah. So but yes, this is something that, I've participated in a couple trials that were just specifically, I was like, advising the people at the Hutch, how to help some rural communities, and Native populations have been one of them. I think, it's another restitution problem. And I think there's a lot of mistrust, and there's some cultural beliefs depending on the tribe, that really don't, where they're against some of the things that we do for care. So the key is to do it in a culturally competent way that helps people. But yeah, no, it's huge. It's huge. Yeah. Yeah. No, but I think it's great to be able to bring that back to communities, and that is part of what we have to do. Is that we have to bring the gains to the community, and have ongoing dialogue, and have people say to you, well, how did you feel in the trial? Right? Because we have to feed back that information, because the people who participate in clinical trials and their communities deserve all the information. Yeah, another target in my mind is, we're not officially affiliated with Hawaii, but the Hawaiian Natives and Alaskan Natives are another group that we are trying to improve things on. So my fantasy life involves somebody coming from Hawaii, getting the medical genetics training at the UW, and then going back to Hawaii to provide that on site. But in the interim, we do telemedicine to offer everybody access to the same problem and the same treatment for the same problem. But it's another huge unmet need for people who live in a different culture on an island remote from care. Tough topic, but I really appreciate the engagement and people willing to speak out. And thank you.
Good afternoon. I hope you all enjoyed the wonderful lunch provided. There's definitely more still on the heaters in the room. If you would like another serving, please feel free to grab more food. Of course, coffee and drinks continue, as well as there's still some cookies left. So make sure that you get some dessert or 3 before too long. So we're going to continue on with the day, a couple more sessions. This one is a panel on palliative care. And our presenters are more than eager to answer questions. And so just as it has gone throughout today, if any questions come up in your mind during this session, just feel free to raise your hand and ask that question. There will be a time for question and answer at the end, but of course, as it has been throughout the day, as questions come to mind, please feel free to raise your hand. So we're gonna jump in and get started. It's my privilege to introduce Dr. Ellen Lee from Swedish and Mary, I forgot, Montesano, who is a Komen employee. She's the manager of Komen's helpline. So without further ado, thank you so much for being here, and let's get started.
All right. Well, thank you, Dr. Yan, for inviting us to speak today. We're going to dive into a case because I thought this might just warm things up to put it in context, because I think we always hear about palliative care in the abstract form, like it's about quality of life or it's about symptom management. But I think it becomes more real in the context of an actual person. So this patient is a patient actually of Dr. Yan and I. And you can kind of see the history of this patient, and there's a lot of science in here, and just wanted to see you to see this 73-year-old woman who came in and to our palliative care clinic, and I've been seeing her for about 1.5 years. And as you can see, she's got some disease in different parts of her body, and she's got complications. So right upper extremity, she's got this neuropathy. It's swollen, it's numb, it feels weird, it's weak. And then she's got some cell counts that are deficient, and she's also having some nausea and some tiredness. And so, you know, in palliative care, how would we approach this person? Well, we collect the same kind of history that we have, especially from Dr. Yan's notes and in the rest of the EMR, and then talk to this particular person, which is a little challenging because she only speaks Cantonese. And so we have to use an interpreter every time. Even though she lives with her son and daughter-in-law, they have never been on one of our visits. Mm-hmm. So they're involved in so much as getting her medicines picked up from the pharmacy. They help her get on Zoom because I've never seen her in person. She can only do virtual because she's that's how significant her fatigue is. And she's on all of this medicine, which she can't read on the bottle. So there's translation in Chinese characters. And then for the ones I refill and work with her on, she holds the pill bottle and spins it around on Zoom camera. So I want to turn it over to Mari.
Okay, so we're just gonna kind of talk a little bit backwards, but so I help run our helpline, and we have a bunch of lovely navigators that do a great job at helping people just navigate everything. So it can start with someone calling. So in this instance, someone calling, we can use our language line, so anyone can call us and we can speak to anyone. And then they kind of just spill everything that they just don't know what to do or what's going on. And it can be anything of just, I'm overwhelmed, I need help. I have family, but I don't have the support I need. don't have any money. I need financial assistance. So anything can start the conversation, and then we can do like a little bit of assessment, a barrier assessment, connect with our long-term navigators, and they help create a specialized care plan that can help people, like, so that they can help them walk through different things that are going to pop up, right? Like, it's not going to be all the issues at once we're going to fix, but the first one might be, they need help navigating finding care in the home. So, we refer to local agencies and we help connect them to local agencies. We're not just giving them a phone number to call, but we help call with them. So it's things like that that we help navigate. And I think one of the bigger things that we help with is just education on who their team should be. So, some people don't get that social worker because they just maybe don't say the right thing to the provider that they're seeing that makes it seem like they need that support. So we help educate and do that warm connection. So we're like, we'll find your social worker, we'll find your team, and we'll help connect you so that you feel comfortable talking to them. And we can work with the social worker as well to help find different resources and support. So that kind of comes along with, we also help with connections like to palliative care or any other support. And we will also sit with the patient. If they have no support, we'll sit with them on the phone with it during the doctor's appointment. We'll help create questions beforehand so they feel prepared going into the appointment. So really just navigating the whole journey with whatever kind of roller coaster they're on that day will help them and be their support during it. So this kind of just highlights a little bit about what our Komen Patient Care Center can do. So a little bit of what I said: emotional support, education and information, connect to resources, access to care is a huge one. We will help find providers, help get second opinions, help with clinical trial access, and just overall just navigate the healthcare world because it's just such a confusing space.
So I'm going to take you through the actual palliative care consult that I did for this person, so you can see firsthand, what does palliative care actually do? So we take care of, these are the global areas. We take care of pain and symptom management. We take care of psychosocial assessment, spiritual assessment, and we talk about goals of care, and I'll show you what that means. And so none of that seems scary to list out, but for a lot of different reasons where we get lumped into hospice and palliative care, it feels really scary for patients and for doctors to refer to our clinic, that we're just all about death and dying, or we're all about just sending people to hospice. And you can see from this list, that's not really a part of this list. It may get into goals of care, but it's a small minority of it. So this person fills out what we call the Edmonton Symptom Assessment System. So this is a 0 to 10 scale on the most common symptoms that we see in our palliative care clinic. And we do this for every visit for every patient. And so this is what she filled out. So, she's obviously having some pain, but she's having significant fatigue and her appetite is not good. So she filled this out. And the other things, I'm sorry, I'll get into the other things she fills out after I talk about pain. So she's having different kinds of pain. She's telling me she has bone pain. She's telling me that right arm, like it feels weird. It feels like an electric sensation. Sometimes it hurts, but it's not the same kind of pain she's having at the local cancer site. And then she's having the actual cancer pain. And then she's got some non-cancer related issues because she's got arthritis in her hands. So all of that needs to be addressed, but all of that needs to be addressed in different ways. And you can see what she's taking. We started her on some gabapentin, and then we titrated her up all the way to 600 milligrams 3 times a day. We had to do it slowly because it makes her more tired during the day. So I started her on a nighttime dose first, and then ratcheted up the daytime dose. She's on morphine twice a day, the long-acting kind, for her baseline pain. And then she takes oxycodone for her breakthrough pain. And for her, it's not that significant 2 to 3 times a week because she's really afraid of it. So she doesn't take it, and I've asked her to liberalize her dose, but she really doesn't do that. And, you know, really that's up to her to decide that. She has bone pain, and I'd love to put her on some steroids, but because of her therapy, I can't have those things interact. So the bone pain is sort of taken care of by the morphine and the oxycodone. But typically for bone pain, I would use steroids and non-steroidals. Those are the treatments of choice for bone pain. And then for, you know, we do, even though I mostly take care of cancer patients in my clinic, I have to be an internist too and take care of arthritis in the hands. And so she takes Tylenol for that on occasion. And then we're trying some topical Voltaren, so topical non-steroidal. Oops. Here are some of her non-pain symptoms. So she's got all that tiredness and she's not really wanting help with this because I offered her some methylphenidate, which is often what we use for cancer-related fatigue. But she agreed to take a 10-minute walk every day. She thought that that was something that she could manage and do on her own, and that was not too daunting. So we're starting with that. She's going to be constipated because every pain medicine causes constipation, and it forever causes constipation. You never get tolerant to that aspect of it. So she's got some Miralax to take, and her appetite's not great. So she's already been seen by a nutritionist. She did not want help with medications. There are medications to help with appetite, but she agreed that small, frequent meals were okay with her. So we talked about what a meal means. So 6 small meals a day. A meal could be half a banana. And I often tell people, use a teacup saucer rather than an actual plate, because that seems more doable. And then, you know, nothing is more unappetizing than a mountain of uneaten food. She is not sleeping great. It did get better when we added the long-acting morphine, but the gabapentin does help her sleep, but she's still up and down a bit during the night. So she didn't want to have a separate sleep medicine for this. So it's really important. Obviously, you see, like, there are available meds, there's available therapy, but not everybody wants everything. So being willing to work individually with each person is so important in palliative care. Let's see here. It's not advancing. Help. Thanks. Okay. So we talked about some of the physical symptoms that she's having. And a big part of what I showed you in one of the earlier slides was the psychosocial aspects of her care. And this is the GAD-7. This is how we address anxiety. So on that original Edmonton score, we said 0 to 10, are you anxious? 0 to 10, are you depressed? And so in our particular clinic, if they score anything but a 0 on anxiety, we ask them to fill this out to see how anxious are you? Is it interfering? Next slide, please. Okay, thanks. And then this is the depression scale, and this is the PHQ-9, because there's 9 questions. And so you can see some of the questions that are asked regarding depression. But you see some of them are physical issues, like staying and falling asleep or being tired. And that could be due to the disease itself and not due to depression. So it's really important for us to have a follow-up conversation after they fill this out to see whether it's truly depression or it's caused by the disease. So, you know, she filled these out. She never fills these out. She's the one patient. She doesn't like to fill them out. She always says 0 on the depression and anxiety because she says it's useless to feel that way. You know what I'm talking. So she's like, and so if I probe any further, she's like, I just, it's not worth talking about because I don't feel that way. And so, you know, because I was trying to get a sense of like, have you had depression before, which is a chemical issue we need medication for, or is she demoralized because her situation is not the situation she likes, which is a very different treatment. That's not going to be helped with medication. And it's important to work with a social worker or a mental health specialist on something like that. So I was trying to parse that out in clinic and she wouldn't go with me. So, and some of the difficulty is in the interpretation. So like, you know, translating it to Cantonese and then translating it back to English, I'm not quite sure what got lost in the translation or in the cultural differences. And then, so, you know, the questions we go into with psychosocial, usually with people is like, what's going on with work? Are you off work? Are you on FMLA? Are you on short-term disability? And that's where somebody like Mari, or, you know, we have an embedded social worker, works with the patient. She says she is retired. She's in her 70s. Her son and her daughter-in-law both work during the day. So she's home alone, which is so far okay. And like I said, the family is helping sort of, like they'll help to a certain extent, but then part of it, I think, is that she's not asking for more help because she feels bad to burden them. And then part of it is that the family's busy too. They have to make ends meet and finances are very stressful. So there's not enough money in the household to cover everything. So that has been hard for them. So this is what we call goals of care. And I don't know if you guys have heard that term. This is what we use. This was developed actually in the Ariadne lab. You know, Atul Gawande, the author of Being Mortal, he had that checklist manifesto. So this is kind of the checklist of a goals of care conversation that they have offered. And we've embedded this in our electronic medical record. And you can kind of see, like, what's your understanding of where you are with your illness? You know, because you would be surprised at who can answer this and people who cannot. And or people who are kind of like, I don't really know. Or, and in our EMRs, there's answers like a checklist in there that says like, what's your understanding? And it'll say, I'm getting better, I'm stable, I'm getting worse or deteriorating, or I'm terminal. So it's first most important for us to understand where the patient and family's understanding is before we start giving off all this data. And then we ask, what are your information preferences? So are you the type of person that likes all the details and all the data? Or does that freak you out and you just want all the big picture? Or do you want no bad news? Like, don't give me any bad news. And then I give them a follow-up question. If you don't want bad news, who is an appropriate person in your support system that I can give bad news to for them to relay or them to know and plan? And then it's our time to share prognosis if we have it. And so we often ask, like, we have to preface that as, do you want to talk about prognosis? Or if prognosis were available, would you want to have it? And I would say in 20 years, I would say 99.99% of people want to have it. We don't share prognosis in palliative care like you have 6 months or you have 4 months, because we can't accurately predict that. In the computer at our hospital, it says same thing, getting better, getting worse, deteriorating, terminal. But we can also say you have months to years, weeks to months. You would potentially be hospice eligible, which is 6-ish months. So we can talk in generalities about prognosis. It is infinitely harder to prognosticate somebody who's farther away from death. So the closer you are to death, the easier our prognosis is. The better your doctor knows you, their prognosis is less accurate. You would think it's the opposite, but it's because your doctor starts to like you a lot. So the doctor feels invested and overestimates prognosis by usually threefold. Threefold. Okay? So let's say you have, you have 1 month. They'll say 3 months. So 3 times longer. Because we're wishing too for longevity. We talk about your goals. So you could say well, my goal is to get cured. Right? At the beginning, it's that. But then your situation changes. We need to have this conversation again. My goal is now to live until my daughter graduates from high school. My goal is to not be a burden or not go back to the hospital. So there's some examples of that. To be at peace, and then fears and worries. Oftentimes when people can't sleep, they're there's certain things going through their mind, like, am I going to get cured? What does death look like? What's going to happen to my disabled son? So we get that out in the open. We have to talk about that so we can do some things to help them. It's not that we can take away the fears and worries, but we certainly can talk about it and see what the social worker can do, what the chaplain can do on our team. And then function, I phrase it this way: what are the minimum specifications on what you consider life to be? What is the difference in your life between living and just existing? So, meaning, what's your quality of life? What's your minimum quality of life that you're willing to tolerate? Would you live on a ventilator without being able to wake up? Would you be okay not being able to toilet yourself? Would you be okay if you couldn't talk? Would you be okay if you could not get out of the bed by yourself? So where do you draw the line? And it's different for every person. And then also, if you got sicker, how much are you willing to go through to gain more time? So another way to phrase, what are you going to do if you, what are you going to get out of life by doing X, Y, and Z? Dialysis, intubation, more chemotherapy, those types of things. And then, does your family know about these things? So we all have advanced directives or pulsed forms and things like that, but that's not as detailed as this. This is more like values and preferences, like who are you as a person and how does it relate to your healthcare? So we did a goals of care through a Cantonese interpreter. And let me tell you, we had to do this over several visits because you can't do all of those questions in one visit usually. And so she said she's stable, and I believe she is. I agreed with her on that. And then her strengths are her family and then her Buddhism. And then she had this global wish was to have an acceptable quality of life by selective medical treatments balanced with avoiding burdensome treatments. That's what she thought she had. That was her global perspective on her care. So like I said, prognosis, we have to ask, do you want to know? And will it help make your medical decisions? Will it help make your financial decisions too? And will it help with planning, a lot of it's travel. I see a lot of patients who want to travel and can they go? Can they skip chemo and go? Then we have to talk to the oncologist and make sure that that's going to be okay. And then how accurate are we? And are you okay with a bit of gray? It's not black and white. It's always going to be a little bit inaccurate. Okay. So that's kind of the first case. And I didn't know if Mari.
I just wanted to go back to the goals of care
Sure.
to just recognize that it can be overwhelming. and that's why obviously it doesn't happen in one visit.
Yeah.
But just that the questions are big, but ultimately they can be very powerful for your family or loved ones to know what your wishes are, because it gives them some control. It gives you some control of what you want that to look like. And so, although it does seem very overwhelming and hard to answer some of these questions, I would say that they're probably the most important, because it really can it can give you a sense of relief once they are answered, because you can feel some more control of what could happen.
So we just got through one case and we wanted to open it up to any comments or questions. Like, I mean, does it help to kind of see this concretely in a patient, to see what palliative care is? Any experiences you've had?
Yes.
I was just going to say, I was just diagnosed, I'm only 38, was diagnosed 9 months ago. And I have a great support system, and my mom and I are very close. But as we've been progressing and I'm getting treated at Swedish Edmonds, my oncologist was like, why don't we speak with palliative care? And my mom had worked in the medical field, so she was like, yes, that's a great idea. And I was like, no, I'm starting to panic. And it has been the greatest thing, just only the last 3 or 4 months. We go sit together, I go separately, and I can say that it is definitely, it's almost, I don't want to know, it's like, it's helped me in like a therapeutic way.
Yeah.
Okay.
To talk out feelings and things as I'm navigating this journey. So,
Wonderful.
highly recommend.
Thank you for
Wonderful.
sharing.
Thank you for sharing that. Yeah. Yes.
How do I get it? Does my doctor have to
That's a great
That is
question.
a great question.
Yeah.
I think that can be an easy and a hard question. Your doctor can order it or ask for the referral to be put in. Your insurance should cover it. I say should. It should cover the consult. And now it's just depending on where you live and if it's available. I think that's the harder part. But if you live in a bigger city, there tend to be more options for you. Yeah, so you're good.
Oh, you're good. Yeah.
So it looks like it's a very well-rounded program. It's not just a medical doctor.
Yeah.
Right.
Quite a number of other things that go around it. Do you guys ever, someone presents with fatigue and exercise helps with cardio?
Yeah.
Get out and walk for 10 minutes. Do you guys ever prescribe like a personal trainer or somebody that helps them do that? Physical therapist?
You can definitely, I think there's a lot of research in like prehab and all of those different types of things that like a physical therapist or occupational therapist, like you can get an order to see one, definitely, to work on strength for what's reasonable for what you are going through in that moment.
Yeah. In our institution, we have cancer rehab as a discrete department. So we, and they have like the active program for breast cancer. And so there's prescribed programs for breast cancer patients in our institution, and Dr. Hebert runs that. So in the larger institutions, they have cancer rehab, or they have specific physical therapists that work with people. Yeah.
Do all of the major hospitals have palliative care? Say like Kaiser?
Kaiser has palliative care here. Yes. And they've been pretty good about staffing inpatient and outpatient, so clinic-based and hospital palliative care program. Most hospitals that are large have palliative care, and there's some certifications that you can't get if you don't have palliative care in your system. And then there's also cancer-related certifications that you can't get if you don't have palliative care in your system.
But then you definitely have to request it.
You do have to sort of, yeah.
Sort of, yeah. I would say, it just depends on where your provider probably thinks you are at in that moment. But I think anyone can benefit from palliative care. You don't have to have a stage 4 diagnosis to seek out palliative care. But I think it's important to start the conversations early.
So in what we created was not for breast cancer, just because the sheer volume would be so vast, but for all pancreatic cancers, all acute leukemias, all glioblastomas, and there's one more that I'm not getting, but they are mandated to come through our palliative care program. So it doesn't have to be urgent because, the diagnosis didn't happen and then suddenly they need to. So we just kind of send them all through our palliative care program, and at least they have some sense of what we can provide. And some of them are kind of like, it's so early that they're sort of like, I don't know what I need from you. But then later on, they may need us. So it's good to know them. But certainly, and I can make the argument that in all metastatic breast cancer, you need palliative care at least to come touch your life at least once,
Do you ever have like a palliative care consult and then you don't see the individual or family for 6 months, a year?
Yeah. I've seen patients and then I don't see them for 3 years,
Okay.
which is just long enough for them to be a new consult again. So I think that there's a lot of folks that, especially with acute leukemia, I think they do that. And sometimes with breast cancer too, because, you feel like all your needs are being met by your oncologist. And so you're kind of okay. And you may not have all of those symptoms or complications right off the bat. And you may live with breast cancer for a decade. And so then, 10, 12 years goes by and you're like, well, maybe your oncologist may mention it or you hear about it at a talk and you're sort of like, well, maybe I could use something, and then, it's good to come and make sure, there is some data to show that people who get usual oncology care and palliative care coinciding live longer and with a higher quality of life. So there is demonstrated data for that. We don't know exactly what the ingredient from palliative care is, but perhaps it's just the attention to, the symptoms. Maybe it's just, the psychosocial assessment. Like, we don't know what piece it is, but they do live longer and live better. So I often tell patients, like, I have the same goal as you. I'm not the death doctor. I am here to watch you live longer and live better. We want the same thing.
My doctor sent me to palliative care because we had been trying to manage symptoms for 5 or 6 years. And she decided she wanted somebody else to come in and look and see if she was missing something or if there was something else that they had that they could do to alleviate the symptoms.
Yeah, I mean, because if you look at like a typical oncology visit you'd have, it's really packed. I mean, it's full of data and side effects and chemotherapy and cell counts and scans. And then where in that visit are you going to fit in a 30-minute time to talk specifically about the nuances of your pain and the timing? Yeah, or got you. Right. So you need to, we provide that extra layer of support where we can talk about your pain for 20 minutes only and try to work on things. We think about all the adjunctive agents. Would marijuana help? Would gabapentin help? Would duloxetine help? Would a cold compress help? We can talk more in detail about that. And then I think that is the added benefit of an already packed oncology schedule where you have just so much already on your agenda with your oncologist too. Yeah.
So that was really helpful because he could explain things very difficult to me, and I really appreciated that.
Mm-hmm.
So I had a pretty bad reaction to the surgery, and had lung problems because
Okay. Wonderful. Anything else? Anything for Mari on Navigator side? Oh, yes.
So Mari, your services are institutional agnostic, right? So patients can access your information
On our website, Susan G. Komen. Yeah. But our navigators can help anywhere, any institution. We're happy to help. We get calls from everywhere across the United States. So, yeah, anyone. Yeah.
Okay. So let's see here. We'll go back. Okay. So this is a younger patient, and I think we had somebody here who is also young. And so this is very different when you're younger and you get diagnosed, because there's a whole host of different things to consider. And this particular patient I'm seeing in clinic, and I say in clinic, a lot of times palliative care programs start in the hospital, but we are unique in that we have a clinic presence as well as a hospital presence. So I feel very lucky to be in an institution like that. And I met her in clinic, and she has metastatic breast cancer. You can kind of see her trajectory since 2018 until now. And this,
It's the same kind of thing, yes. But I would say this is more of our typical kind of call. We get a lot of younger women calling specifically on being re-diagnosed. So now with stage 4, very overwhelmed, where we provide a lot of emotional support. And it's sometimes it's like they're walking outside of the doctor's appointment after being diagnosed, and we're just walking them through their emotions at that time. We have specific, like I said, MBC care plans that we help walk people through. And specifically with a younger one where there's a lot more things that come into play, FMLA, disability, work, financial, kids, all of those things, that we can help walk through the different steps and just different resources out there for financial toxicity and just who their team should be. So again, that's just another thing that we can do as a navigator. I would just skip.
okay. So again, I had this patient fill out the Edmonton symptom assessment. And then for her pain and symptoms, she said she had 4 out of 10 pain in her left hip, her left shoulder blade, and then it radiates down that same arm. And we weren't sure what it was because she hadn't had her PET scan yet. So we're kind of working blind here. She was taking methadone, which everyone associates with like drug addiction, and it's not. It is it's very, very good for neuropathic as well as cancer pain coinciding. So she's taking this tiny dose at bedtime, and then she has Dilaudid and she has Tylenol, but she hadn't taken any Dilaudid in 6 months because she gets constipated immediately afterwards, and she feels like nothing helps that. So she's like, I'd rather just have the pain than get so constipated. And she said it was even worse with oxycodone, so she tried another agent. She's got gabapentin at a pretty good dose, 900 milligrams. So the nerve doses are about 1,800 to 3,600 milligrams a day. So most people are like, oh, gabapentin didn't work. And I'm like, well, how much are you taking? Like 300 twice a day. I'm like, that's not gonna work. So occasionally it does, but mostly you need the higher doses. And then she was having this headache, and she said it felt like pressure. So of course, where does her mind go? I have a brain met. Yep, that's exactly right. So then she went, because I just saw her yesterday, and her headache's gone, so she canceled her MRI. So she was nauseous more at night, and again, she just really didn't want to take meds. And ondansetron was the med she had, and she didn't want to take it because it's also constipating. And then her sleep is very poor, and she takes some Ativan when she's unable to sleep, unable to turn off her brain, and she feels restless. She has a lot to feel worried and restless about. She is currently unhoused so she bounces back and forth between her daughter, who's like 20, and her apartment and her mom's house. Because when her husband found out she was diagnosed with cancer, he left.
He said he couldn't handle it. So she couldn't afford to pay the mortgage on their house, so they lost the house on her own. So she's really struggling with sleep because there's just so much to think about. She says with FiberCon, she can have regular bowel movements. With FiberCon in a younger person, I'm kind of okay because the fiber products just need a ton of water and you need to be able to move around. Otherwise, you can get a Bezor in your stomach and cause an obstruction. So if it's like an 85-year-old person who's not eating, not drinking, not moving, I really take them off the FiberCon. But for her, we left it on. She's tries to eat 3 meals a day, but she's lost 30 pounds in 6 months. So that's partially, I think, from the disease, but partially because she's just not coping right now. And then for the anxiety, she's taking a bit of lorazepam. Again, okay in a younger person. Over 65, we do not recommend this category of medicine. No benzos for people over 65. It promotes falls and cognitive impairment. This is her goals of care note. She was the only one there. Her daughter knows what's going on, but she's 20, so she's trying to let her be 20, like not burden her. She says she's never asked about her prognosis, and she thinks she's unstable because everything's still changing right now. But she would like to be fully informed about her prognosis. I thought I agreed with her that she was unstable, but she would want to know once the information were available. And she says she's got family, her daughter, her friends, and she has a couple friends, but she had to move, so they're not close to her anymore. And then she says she's not religious, but her spirituality is just being kind to others and being out in nature. That's her church's nature, she says. And then she says it's okay for us to talk to her daughter if we want to, or talk to her mom about any of this kind of discussion. So that's kind of her. Mari, did you want to add anything?
It's a tough one with
Yes.
unhoused. We get a lot of calls with, and those are our higher barrier needs individuals that call, but a lot of individuals calling that are unhoused and trying to go through active treatment, which is the toughest thing because then it can be unsafe to go through active treatment as well in certain situations. So we definitely try our best as well to get in touch with, local resources or get them in a shelter, whatever we can do to help, definitely. But it's definitely a bigger issue right now.
Yeah. I think the hard thing for her is she's never been in this kind of situation. She
Yeah.
was just like a suburban mom. And then suddenly she's thrown into this situation. So
the
she's
support
having
leaving,
trouble even knowing where to look for resources. So that's been
Well, and I
hard for her.
think support that just leaves is hard.
Yes.
I think a lot of what I've heard from a lot of individuals, and maybe you all can say this as well, is when someone is diagnosed with cancer, their friends, loved ones don't always know what to do or say. And so sometimes you lose those people. Sometimes they stick, others stick around because they just don't know what to do or say.
All right.
Any questions? Comments?
It depends is the answer. So I think if it's like gabapentin or something like that, usually we're okay, prescribe. If it's something like steroids, you always walk across the hall and talk to the oncologist before you prescribe steroids. They will get very angry at you if you do that. You walk many miles as a palliative care doc starting out in an oncology practice, coordinating and making sure all of your recommendations are okay and what you said to the patient or what you're gonna say to the patient is okay. So tons of coordination has to happen, not just to build the trust in the patient and for coordination of care, but for you as a palliative care doc to have any inroads into the oncology world. There's a huge ramp up of trust and rapport building that you have to build with the oncology team before you can do anything. Otherwise, they will never call you again. Yeah, so lots. Sure. Mhm. Yeah, so on our inpatient palliative care teams, so I have 4 teams under me on the inpatient side and 2 clinic teams under me. So the 4 clinic or the 4 hospital teams all have chaplains on them. So, or spiritual care. If we need somebody on the outpatient side, one of those chaplains will reach out to the patient and then also help with connection into the community that matches their faith. Yeah, it's a great question. Yeah.
When my kids were growing up through the school system and had individual IEPs, individual educational programs, one of the things I discovered is that the school district wasn't able to offer recommendations unless they would pay for it. Is that true with you guys as well? So like things like, I recommend maybe, so what are your thoughts?
No, we can still recommend even though it costs out of pocket. Like, one that comes to mind immediately is like acupuncture. So like oftentimes I'll say, hey, like I think that there's some data on acupuncture and dry mouth to help with dry mouth. And so I don't check on what the cost is or anything like that. I just make a recommendation. Yeah.
The social worker can help find different options if it needs to be, but sometimes insurance does cover for acupuncture, depending on your health insurance. I think most do now, but there are different clinics that will help with like sliding fee scales as well.
Welcome back for our last session of our time together today. It has been absolutely wonderful time together. So, and we have one more wonderful presentation this afternoon. Dr. Dolezal is joining us from Stanford University, and we're very excited to hear about the future of MBC treatment. So, join me in welcoming Dr. Dolezal. I'm going to unmute.
But at any rate, thank you so much for having me. It's great to be up here. My name is Milana Dolezal. I'm an associate professor at Stanford University. But just to be clear, I'm in a community setting. So I'm a community hematologist and oncologist. So I wear a lot of hats. I work out of Emeryville, which is Oakland area. So we actually have a very diverse community, a lot of Black and brown people. I also work with I'm the physician champion for the Native American Health Association. So we have a big area down in the Oakland area, and actually working with the new CEO, Natalie Aguilera, to Adrian's comments about something called longevity. Not only longevity, but land. So we have a homeless problem. We have patients that can't get care and can't have places to live. So I'm really involved in my community. I bike to work. I bike my kids to school and work. I sit on a lot of different boards and do a lot of other stuff. And I also am very passionate about cancer survivorship and thrivership. So I've started different programs in cancer survivorship. And, in a concert with what we heard from our palliative care colleagues, a lot of it's about supportive care. So these side effects from any of these medications, even pills like aromatase inhibitors, we make young women postmenopausal. They have sexual health issues. I've run different clinics on sexual health well-being and really being a whole person. So just because you have a cancer diagnosis, we don't need to ignore your symptoms and not handle your symptoms and only treat the cancer. So it is within your oncologist's wheelhouse to address these issues, or at least to give you the appropriate referrals to figure out how to get help. So that's my little spiel. In terms of what I'm going to cover, this is a lot of information. I'm really going to decrease the scope to really the last 2 or so years during this pandemic, approvals during the pandemic, but there's going to be some introductions that we're going to have to do around making definitions, defining stuff. And for full disclosure, I'm also a scientist, so I get a little bit geeky. So please pay attention to me and not only the slides, because the slides are going to have a lot of information. I'm also not a statistician, but I can explain a Kaplan-Meier curve. But I'm going to talk about how we target the outside of the cell. So these are with antibody therapies. You might be familiar with Herceptin, pertuzumab, trastuzumab, and Perjeta. And then newer agents, antibody drug conjugates. So we heard a little bit of that from Dr. Fan. I'll present some of that data as well. I know Cindy, unfortunately, has had a side effect from Enhertu or trastuzumab deruxtecan. I'll talk about that. But how do we target the outside of the cell to shut those signaling pathways down, develop agents that deliver chemotherapy at higher potency into that cancer cell? And then I'll touch upon the inside of the cell. How do we target the inside of the cell as well? And then what about immunotherapy? Immunotherapy is also transformed treatment of multiple different cancers. But how do we get our own immune system to fight cancer just like it fights bacteria and fights viruses? So how can we get smarter in how we do that? So this is a super busy slide. Let me walk you through it a little bit. So the point here is breast cancer is a family of diseases. It is heterogeneous. It's not just one diagnosis, okay? So we've gotten a little smarter over the years. On the left side of the slide, you can see microarray data. Again, geeks coming out here. In terms of some of the mutations that happen. And we've known from the beginning that not all estrogen-positive breast cancer is equal. So there's luminal A, which is a little more like putter-along kinds of cancers. There's luminal B, which can tend to be more aggressive. And so in terms of the prognostic aspect, understanding, is this a good, not so good, or really bad cancer? Because there's implications for that. And then also predictive stuff. What can we predict as a benefit from therapy? So we have gene profiles that look at the tumor. You may be familiar with the Oncotype DX, 21 gene profile. Do you need chemotherapy or not? Predictive for chemotherapy benefit. There's another one called Breast Cancer Index. Do I need to take more than 5 years of this pill that gives me no libido and I can't have sex with my husband and I ache like an 80-year-old all the time? Do I need to really do that? Or is it affecting my bone density? Is that something that my breast cancer needs? So those are the ideas around some of these predictive prognostic. And then knowing your genes. So this is not only the cancer genes, the germline stuff, the mutations, which we have blood tests for now, liquid biopsies, whether it be Caris, Guardian, Foundation, Tempus, there's several of them. Also your germline. According to the surgical guidelines, all breast cancer patients should have genetic testing. Doesn't matter if you're 38 or 72. Certainly with triple negative breast cancer, we've been doing that for a while. But we have targeted therapies for that, not only for the inherited stuff, but also at the tumor level. So I'd like to use the analogy that I stole from George Sledge, who's an amazing individual. He just left Stanford recently for Caris to work on some of these targeted platforms. But he said breast cancer is like a family of criminals, okay? It's a family of criminals. You've got petty theft and you've got mass murderers. Well, you know what? We punish them differently, don't we? So think about it in that context. It's not just ER, PR, HER2. Those are the ones we're familiar with. But we're really refining all that in terms of what you're seeing here on the right side of the slide. I happen to also be a triathlete, although as I age, I have a lot more orthopedic issues. But this is the Escape from Alcatraz Triathlon. That's probably me in one of those little caps here. But what I'm trying to tell you here is that we also can pick up circulating tumor DNA in patients' bloodstreams now. So this is well validated in colon cancer, and certainly in high-risk breast cancers, we're doing more of this to understand, are you at risk for recurrence? We don't necessarily do surveillance in early breast cancer in terms of head-to-toe scans. Can we pick something up earlier? So I think we're getting a lot better not only in defining these subtypes, treating these subtypes, but catching them early, those little escapees from the Escape from Alcatraz. All right, so it gets even more complicated. This is one of our colleagues at Stanford, Professor Christina Curtis, who's really subdivided estrogen receptor HER2 negative types of breast cancers to 8 subtypes. And these little I1s are worst prognostic types of indicators. Well, what about the predictive part of it? Can targeted therapies overcome some of this endocrine resistance? Can we be better at how we kind of figure it out? And have a clinical trial with her in the early breast cancer pre-surgical setting as a playground to kind of test out some of these agents to understand how they work on the signaling level of the breast cancer. So using other agents that we would try and test out to see if we could shrink the tumors more. So you guys are probably familiar, I talked about HER2 positive breast cancer. I had the privilege of doing my fellowship now, 20 years ago, at UCLA with Dennis Slayman, who really pioneered this treatment antibody therapies for HER2 agents. And then I was lucky enough to go to Genentech to actually work with the FDA on the original filings in the adjuvant early breast cancer settings for Herceptin, trastuzumab. And then I worked on Perjeta, TDM1, which I'll talk about as well, and even some of the early PI3 kinase inhibitors. So it is really a topic near and dear to my heart. But when you talk about HER2 positive breast cancer, you can see here, it's kind of like one of those weird globes that you put your fingers on way back when. But at any rate, when you get more of these extracellular little antennas on the HER2, that is HER2 overexpression. And it sends those cancer cells into overdrive. They are just proliferating, they're dividing, they're growing super quickly. So that's kind of what it looks like on a cellular level. Lots of little antennas. And typically, we had sort of thought of HER2 breast cancer as either being negative or positive. So positive really being 3+, and this is standing on the outside of the cell. So these are actually the protein extracellular receptors that you can look at under the microscope when you do a biopsy or the surgical tissue or any biopsy. And it's really how brown is it? So you can see on the left side of the slide, 3+, really brown. Lots of those little antennas on those cancer cells, highly overexpressed. But we're learning now, and this is relevant because we have targeted therapies that are better now, there's a spectrum of positivity, right? So you got a little bit of light brown, that's more of a 1+. You got the in-between brown, sort of shades of gray. And we are able to kind of refine our treatments based on this spectrum of HER2 positivity. So this idea of HER2 low, I'm going to talk about it in the context of some of the new antibody drug conjugates, but it used to be, okay, well, we treated HER2 positive breast cancer, i.e. breast, in one way, and then we treated HER2 negative in a different way. But we have found through a lot of work that Dr. Tarantino, who's at Dana-Farber Harvard, has done, is that HER2 can be a continuum. HER2 low is actually pretty common in hormone receptor positive, estrogen positive breast cancer. So it's about up to 55 to 60% of patients who have hormone, HR, ER, and or PR positive breast cancer can have HER2 low. So it's not necessarily a new subtype, but it is a targetable subtype. And that'll be really relevant for some of the treatments I'm talking about. Do we have any Thomas Keller fans in the audience? No. I'm from the Bay Area. I celebrated a big 0 birthday during this pandemic, so I had the honor of meeting him, and my husband took me for a special dinner there outside. But at any rate, I'm not a pig eating person, but I understand there's different parts of the pig. And I'm not sure why the pork butt is in the shoulder area, but I understand it's pretty crispy when you cook it up. So I want you to think about all that in terms of when we talk about even within one patient and one organ, if you have liver mets, they can be different, completely different, okay? And when I explain things to patients, and this could be across any type of tumor, you have a lot of different areas within an organ. And if you did a biopsy, this pizza analogy, maybe you just get the cheese. That might not be as informative. We might not have the receptor status or this HER2 low. So what about the pepperoni, the sausage? How are you picking all that up? This is also complicated, but this is a really interesting study. So this was up to 10 patients. About 6 of them are shown here. And these patients not only had biopsies from original breast biopsies or surgeries, they had metastatic biopsies. They also had autopsy tissue. So they went through, once the patients had generously agreed to allow their body to be autopsied, went through the liver, all these different sections of the liver. On the left side of the axis are 6 patients and multiple biopsies, sometimes even 10 patients. Look at all the different shades of brown orange here, right? So you've got one section of the liver here, B, with patients 3, very orange, very brown, so that's really HER2 low, 2+. But then when you just move over to section E, not too far away, no staining. So even within one patient and one organ, you can have discordance and heterogeneity. Well, this is interesting. So the numbered biopsies you do, eventually you're going to find a HER2 low. So if you do 5 biopsies, one of them per the ad hoc is going to have HER2 low. So just keeping that in mind, about a third of patients converted to HER2 low with each successive biopsy. So I want to outline lines of therapy. As I segue into talking about treatment, this is really important to understand lines of therapy. What does that even mean? So when you're first diagnosed with either de novo at diagnosis, stage 4 metastatic breast cancer, or unfortunately you had treatment which we thought was curative 10, 15 years ago and it comes back, the first therapy you get at that stage 4 diagnosis is called your first line therapy. And I have to say that when I first started in oncology, again, some 20 years ago, that there weren't really more than 3 lines of therapy in the metastatic setting. And patients really weren't living more than 2 to 3 years. And now with some of the data I'm going to show you, and the bottom part is sort of arbitrary there in terms of the years, we're getting into 4th line, 5th line therapy. Patients are living 15 years, et cetera. So this is really to what Dr. Fan was showing earlier, some of the data from my colleague Jennifer Caswell that was presented in JAMA. These are the revolutions in treatments, and these why people are living longer with this disease as a chronic disease as we live with diabetes and high blood pressure. The other point I just want to make here, and I think this is really relevant when we look at the numbers, is these arrows start to get smaller and smaller with subsequent lines of therapy. So really the biggest bang for the buck is the first line therapy. And hopefully that's many years, plural. And that could be for HER2 positive disease. That could be this Cleopatra regimen where patients are living for 5+ years before a progression happens. And that could be about 6 cycles of chemo with targeted therapies, continuing on targeted therapies alone till the next progression. And then that's considered the second line. But be mindful of the fact that over time, cancer gets more mutations, gets more sneaky, figures out how to evade therapy. So the other piece here is that we've really transitioned this bench to bedside idea, like the laboratory bench, the scientist in me, and some of us in the audience, to how are we translating that into patient drugs and things that can treat the cancer. So when you talk more about traditional medicine, radiation, chemotherapy, surgery, now it's really like, well, what are the genes? What are the genes from mom, dad, whether it be BRCA1, 2, PALB, etc., and what is the tumor using to grow? So it's really this idea of precision medicine to really specifically turn off stuff that the cancer cell's using to grow. So how do we do that? So I talked at the beginning about setting up the different types of therapies. So targeting the outside of the cell with these either ER, PR, HER2, there's something else called TROP2, which is highly expressed in breast cancer as well. So these are things that are going to hit the outside of the cell. So Herceptin, if you can imagine, this is a tree. Trastuzumab Herceptin here hits the base, the trunk of the tree. Perjeta hits the outside. So you're familiar with those antibodies, but now we have antibody drug conjugates, which I'll talk a lot about. These are IV therapies. They have a longer half-life, so they don't have to be dosed every day. They can be dosed, every 3 weeks more commonly. They might not get into the brain because they're bigger molecules. I'll talk about the blood-brain barrier. They don't have a lot of drug-drug interactions because they go throughout your bloodstream IV. On the other side of it, when we talk about the inside of the cell, targeting the inside of the cell, these are oral pills. So they're usually dosed at least daily, maybe even twice a day. They can get up into the brain and diffuse around. There are typically tyrosine kinase inhibitors, these sorts of types of classes of drugs. But because they can hit multiple pathways, including something called the EGFR pathway, you get rash, you get diarrhea, get a lot more side effects, okay? You can also have drug-drug interactions with the list of, 16 pills or something that our palliative care colleagues had put up for that other patient, or even grapefruit juice or Seville oranges. So keeping all that in mind when we talk about these different types of therapies. Well, what about the outside of the cell? What about these antibody drug conjugates? So they've been called smart bombs or magic bullets, or I like the Trojan horse analogy. That's what that little thing is in there. My son is very into all sorts of Greek and Roman mythology, so I like to use this kind of analogy here. But so you bring that directly to the cancer cells. So the structure there on the left is sort of the same with all of them. There's 3 things, okay? So there's an antibody, so that's a train, or the Trojan horse, bring it directly to the outside of the cancer cells. So that could be HER2, that could be TROP2, whatever. There's a little sort of rubber band linker that's linking it to the chemotherapy, the poison, the balls. So the idea is it's really targeted. It's bringing directly to those cancer cells as opposed to chemotherapy. Chemotherapy just kills fast-dividing cells. That's why you lose your hair. That kind of stuff. So can we get better and actually not kill a bunch of normal cells in the process, but actually bring it to those cancer cells to kill them directly? So there's a lot of antibody drug conjugates out there now. I mentioned TDM1 as one of the first ones. Actually, it was created up here in Seattle with Seattle Genetics, subsequently bought out by Genentech. And so these 3 components, I'll talk a little bit about TDM1 in the context of one of the newer agents, trastuzumab deruxtecan, or Enhertu, and then there's sacituzumab and Dato-DXd. But the structure is the same. The poison's a little bit different, the train's a little bit different, etc. But that gives you an idea. So how do these drugs work, and what are some of the differences? Well, I mentioned the structure in terms of trastuzumab deruxtecan, or Enhertu. This is a very potent drug. It has 8 chemotherapy balls. So there's an 8 DAR, drug to antibody ratio. And it's unique as well, and why we think it works better than some of the first generation antibody drug conjugates is not only does it go to the cell, it's internalized, and that could be a HER2 positive or a HER2 low, gets into the cell, and then goes to the nucleus, kills the cancer cell. And what's unique about this one is the chemotherapy is membrane permeable, meaning it can diffuse out and go to the neighboring cancer cells. So you can imagine if you have like a big tumor ball in the liver, and it's kind of like a castle with a moat around it, and you've got these extra cells, these HER2 receptors on the outside, well, it's going to go bind to those, right? But that Trojan horse can't like dig underground and get all the way into the heart of that tumor. But these little chemotherapy balls can actually go down in there and start killing the other cells, neighboring cells that might have HER2 low, HER2 no, whatever. So it's sort of targeting the cancer cells directly, but also having this diffused effect. So Dr. Fang already talked about this New York Times article, unheard of survival, so 29 months, and I'll set up the trial for you here. So this was the DESTINY-Breast04 trial, and it was presented at our oncology meeting in Chicago in June. Wow, almost 3 years ago now, or at least 2 years ago, 2024. All right, pandemic, we've lost track of time. 2 years ago now, it seems like a long time. But the results, which I'll show you on the next slide, were so remarkable that an audience of 30 plus oncologists got up and clapped. And it was a standing ovation, that it was that remarkable. So these are patients with metastatic breast cancer, hormone receptor positive, so ER or PR positive, and HER2 low. So I set it all up at the beginning in terms of the pathology. So 1+ or 2+. Now, because these patients had estrogen positive HR hormone receptor positive disease, they'd actually gone through a lot of anti-hormonal strategies, anti-estrogen strategies. So they'd had maybe tamoxifen, maybe aromatase inhibitors, maybe Faslodex, which is that 2 lovely butt shot, etc. And now the cancer's gotten sneaky. So maybe it's taken those estrogen receptors and buried them so they're not little antennas outside anymore. So this was looking at chemotherapy. They had had 1 line of chemotherapy prior. So it's really like 3rd, 4th line, okay? So getting down there in terms of how many lines of therapy. And randomized to this new Trojan horse, TDXD, versus chemotherapy of the doctor's choice. So that could have been Xeloda, that could have been, there's the list there. And the primary endpoint was what was called progression-free survival. And this was the money shot. So this is why we got 35,000 people clapping. Because in this heavily pretreated 3rd, 4th, 5th line population, compared to chemotherapy, not compared to nothing. So in oncology, it's very rare that we have placebo only. You are randomizing patients to a active therapy, okay? We doubled progression-free survival and improved overall survival. And so this was approved by the FDA in August of 2022. Well, what about side effects? So I know Cindy unfortunately experienced some of the side effects. In the phase 2 trial, which formed an accelerated quick approval back at the end of 2019, actually, we saw a lot of cases of ILD. I don't know why it's on its own journey here. But at any rate, what is ILD? Interstitial lung disease. And so this could be damage to the lung itself. Now, we screen for that. So patients who are on Enhertu or TDXD are getting CT scans every 2 months on the clinical trial. I think out in the community, we're doing it about every 3rd cycle. And if there's any changes in the lungs, then we monitor. They're asymptomatic. But if it's grade 2 symptomatic, we have to stop, and we have to stop permanently. And then we work with our pulmonary lung doctor colleagues now, because not only do we stop, we institute steroids to basically help decrease the inflammation and the side effects of that agent. And we're pretty used to doing that with immunotherapy now that has some funny types of side effects. So ILD, because of the Herceptin part, we're still doing echocardiograms of the heart. This, even though it's smart technology, it's not without other chemo-like side effects. So patients can have hair loss. Some patients, I've even had a full couple patients that have completely lost their hair. So maybe it is that bystander effect. You're still getting some chemotherapy going throughout the body. Nausea is real. And so some of the fancier medications like Emesis and Amend, we're using those. And there's about 4.6% of patients who had dose reductions due to nausea. What about in the HER2 very positive, very brown 3+ staining? So this trial, 03, came before 04, and this was in a 3+ HER2 positive population. Most of these patients were in the second line, meaning they had done sort of first-line therapy, this Cleopatra regimen for maybe 4 or 5 years, and now they were either getting an older antibody drug conjugate, which generally maybe worked for about 9 or so months, maybe not as much as a year, compared to this newer T-DXd. What did that show? Well, again, remarkable results. So I don't expect you to understand Kaplan-Meier curves because I don't even know them that well myself. But what I can tell you is when you look at this, these curves separate really broadly. It's like you can drive the Mack truck through it. We used to have a joke that, did it pass the laser pointer test? Like, could I get the little laser pointer in there? But no, these curves separate quickly. You can see that pretty quickly in that second line stage 4 metastatic HER2 positive breast cancer patient population. They're coming off trial. They're progressing really fast within the first couple of months, almost at the first scan, but not with the T-DXd. And that's that top blue line that you're looking at. And, you had a quadrupling of survival here from 7 months to almost 30 months. So again, with a highly statistical p-value for what that's worth. What's exciting now, and this is just hot off the presses, not even a month ago, is now the FDA has approved this medication across multiple tumor types, as long as it's HER2 3+. I kind of wish it was HER2 2+ and 3+ or HER2 low, but we'll see what happens. So it doesn't matter where it started. It started as breast cancer, endometrial cancer, whatever, across multiple indications. So this idea, like we're not paying as much attention anymore to it's a breast cancer, it's a colon cancer, whatever. What is the tumor using to grow? What pathways is it using to grow? And how do we bang that down? So this is a different antibody drug conjugate. Again, pay attention to me, sciencey person with stuff on the slide. So this is a different one. This is called sacituzumab. So it has a different antibody backbone, another one of these antibody drug conjugates. So it targets TROP2 instead. Also pretty potent, has 8 of these chemotherapy balls on the backbone. And this was a much more heavily pretreated population, meaning in the hormone receptor positive, HR positive population. Didn't matter here if it was HER2 low, because it's a different train, doesn't pay attention to HER2. They had at least 2, but no more than 4 lines of chemo. So you're really talking about patients who are on the 5th, 6th, 7th lines of therapy getting this in the metastatic stage 4 setting. And you saw about a 35% improvement in terms of disease progression. What I think is more relevant too, when we're talking about all these agents, and I can put lots of curves and stuff there, but this particular TROPiCS-02 trial also looked at quality of life, patient-centered care. So it's not just how long are you going to live, am I going to extend your life as an oncologist by 4 more months or 7 more months? I mean, sometimes those things are important in terms of getting to a graduation or a grandbaby being born or whatever, but what kind of quality of life do you have? Can you leave the house? Are you running to the toilet all the time? Can you not even get to the toilet because you have neuropathy? So what is your quality of life? So this TROPiCS-02 trial, and this was presented by Dr. Rugo at our big oncology meeting in 2022. She's one of my UCSF colleagues, also looked at quality of life. And the bottom line is the patients who were on this SASI agent had less fatigue, less pain. So not only we were treating the cancer effectively, decreasing the symptoms, but there wasn't as much toxicity. Now, don't get me wrong, this is not a non-toxic drug. We have to use growth factors and other stuff, but really focusing on the patient-centered care, symptom palliation. Excuse me. Let me grab some water, talking too fast. So this is a newer kid on the block, not yet FDA approved, just wanted to let you know it's out there. One thing to keep in mind here with this Dato-DXd, it's a TROP2 backbone. It has that same chemotherapy poison as the Enhertu, but maybe because it's 4 balls as opposed to 8, we're seeing less toxicity. So we're not seeing that same level of interstitial lung disease that we do with Enhertu or ILD. Good response rates, more than doubling of response rates. So stay tuned for this one. Sure. It's not yet FDA approved, but it's, yeah.
But it is a trial right now, or is it not a trial?
There are other trials using this agent, but I think this trial is close to accrual. Okay, in terms, pardon me? Sacituzumab is, sorry, maybe I'm going too fast. This is a different one called Dato-DXd. Enhertu's approved, sacituzumab's approved. This one, stay tuned. I'm just trying to outline sort of all the research and stuff that's out there as well. The other thing I wanted to point out, and I was at San Antonio this year, which is our big breast cancer conference in December. There are a lot of advocacy groups and patients who can attend as well. Dr. Bardia presented this trial data from this newer agent, and I really liked this slide because he couldn't say every single woman's name. There weren't, I don't think, any male breast cancer patients here, but he had this slide up, acknowledging and thanking the 732 women who participated on this clinical trial. And very courageous, you're taking a risk. Clinical trials are important. They may or may not help you, but certainly they can help future grandchildren and other people. So thank you for giving back. And for those of you who have participated and are on clinical trials, thank you for your service. So a lot more to come. Lots of these. I basically talked about sort of the first 3 on the left side here, but mixing and matching. So different antibodies, different, oh, thank you. Yeah. And different linkers, different chemo backbones. But, over time, I think we are going to get some cross resistance and, what's the best ADC to start with? And what do you do at progression? Are you doing another ADC? Are you trying something different? So I want to point out here that I am a community oncologist. So I do wear a lot of hats. It is hard for oncologists to get all this and know all this. Last year, the FDA approved 45 medications in oncology, okay? I think there was at least 8 in multiple myeloma, which is, I just give that to my colleagues that are experts in that, not me. 17 new drugs in the market. So it's really hard to be the jack of all trades and a master of none these days. And so I think you heard this earlier, get second opinions, get third opinions. I send patients of mine to UCSF if there's a better trial there that we don't have. It's really patient-centered care. I want to do what's right for you as a patient. I don't care if you stay with Stanford, you're going to come back, or maybe you won't come back. It's what you need to be your own advocate. I think we heard earlier about sort of the squeaky wheel. You need to advocate for yourself and certainly participate in clinical trials. A lot more approvals out there. I talked a little bit about this tissue agnostic stuff. So these are different types of mutations that cancer can globally use. We have some breast-specific approvals. I'll talk a little bit more about the ESR1 and the PI3 kinase. So a lot of stuff going on. During this pandemic, to jump back to HER2-positive disease, there was something like 7 approvals, I think, within 2021 and 22. So I talked about the T-DXd on the outside of the cell, but I want to transition a little bit to the inside of the cell now and talk about these agents that target HER2 from the inside, and specifically tucatinib. And why? Well, I think we've talked about sort of the elephant in the room a little bit is brain metastases. So HER2-positive disease likes to go to the brain, has a proclivity for going to the brain. It's usually one of the first sites of relapse. And by the time patients get to the third-line setting, well over half of patients have brain metastases, even if it's asymptomatic or not. So it's unmet need. Not only is in the brain itself, but leptomeningeal disease is what you see circled here. And usually prognosis isn't that great once you have brain metastases, and we've really been trying to do better there. Well, why is that? Why can't our drugs get up in there? Well, there is this SEV, the blood-brain barrier. It's like a net, and it catches things. Not only that, there's also pumps that pump toxins out. So that therapy maybe can't get up in there, okay? So there's all these safeguards, and you have to imagine it's probably evolutionary protection. Somebody had a bad mushroom. Hopefully it didn't kill them. Maybe it made them a little loopy for a while. Maybe they threw up. But other than that, it's our body's way to kind of help protect your brain because, you got to run away from that tiger or whatever it is. So I think that's kind of why it developed. But it is also a difficult disease to treat. And so, again, Seattle Genetics here, which I think was just bought out by Pfizer. Is that right? Anyway, homegrown. So this particular agent, tucatinib, is an oral drug. It was approved also during 2021, during this pandemic, based on this HER2 CLIMB trial. And this looked at trastuzumab, which is basically Herceptin, hitting the outside of the cell, plus a chemotherapy, Xeloda, capecitabine. Some of you guys might have been on or on that currently. Maybe it gets up into the brain. It is an oral pill with the addition of tucatinib. So working not only on the outside of the cell, but on the inside of the cell to try and really understand full blockade. Now, what was really courageous about the trial design here, and kudos to Seattle Genetics, is they included patients who had brain metastases. And in past clinical trials, most patients with brain mets were excluded. And the reason why is outcomes aren't great. You kind of want to cherry pick a little bit in terms of the best performance status, no brain mets, because you want your drug to look better. You want to pick the best population, and then the FDA will approve it. So kudos for them because they realized, wow, this is a huge unmet need. And there are other HER2 oral agents out there as well. But this is really one of the first trials that tackled brain metastases head on. So you could have previously treated stable brain mets that are active, but maybe not requiring immediate therapy. So all these buckets of patients were allowed. They had to have prior treatment with Herceptin, trastuzumab, pertuzumab, or T-DM1. So this is really sort of more of a third line HER2 positive type of patient population, maybe some second line patients as well. Phase 3 trial, lots of numbers, over 600 patients. Overall survival, 21 months versus 17 months, and more than a halving of disease recurrence risk. But even more importantly, when you specifically look at the patients who had brain metastases baseline, who were allowed, their median overall survival was more than doubled. And that went from 11 months to 20 months. So really groundbreaking in terms of this unmet need. And not only does it do that, it helps preventing the next brain met from happening. So unfortunately, we can kind of, we can zap with SRS, gamma knife, stuff like that, but it's just a matter of time in this trajectory and natural history of HER2 positive breast cancer that there's going to be another brain met down the road. So this agent also helped in terms of blocking, preventing the next brain metastases. For fair balance, Sarah Hurwitz is now here in the Seattle area. I worked with her back at UCLA. She presented some of this data looking at TDXD. And there are evolving data saying that TDXD does also get up in the brain. I can tell you I've had at least 2 patients with leptomeningeal disease, which typically has been more 6-month hospice eligible, going from being in a wheelchair with neurological deficits to going back to work full time. So anecdotal experience, this stuff works. Let's switch gears. I know this is dizzying for people. Yes. So that was that first data I talked about, the DESTINY-04 trial. That's for HER2 low and HER2 positive. Tucatinib, this oral pill, is for HER2 positive, so that 3+. You probably heard of CDK inhibitors, palbociclib, Ibrance, ribociclib, Kisqali, and abemaciclib, Verzenio. These work on how cancer cells divide and replicate. So there's something called the cell cycle. Maybe you remember from biology, M for mitosis and S, DNA synthesis. So these things help the cells divide. And normal cancer cells want to copy and duplicate and replicate. But cancer cells basically turbocharge this pathway. And they're growing, they're dependent And they basically are using this pathway to continue to grow. So now we have these cyclin-dependent kinases, CDK4/6 inhibitors, that block that from happening. So it freezes those cancer cells. And now they can't signal, they can't divide, they can't replicate. So this is a super busy slide, but let me just kind of give you the highlights here. Bottom line, lots of clinical trials with this, these 3 agents and all these different names here. But what you see is a consistent doubling of progression-free survival, halving the recurrences across whatever agent that you're using. Now, there's been a lot of controversy around survival endpoints, which one's the best. Does anybody know who that is? Picture of that? Yeah. So I like to say it's messy in terms of the whole overall survival discussion. It's too bad he's not with Barcelona anymore. But anyway, you guys saw the World Cup. So these agents have different side effects. So abemaciclib, Verzenio, is one that does seem to get better up into the brain, but a lot of diarrhea. So in terms of the symptom management and palliative care stuff that we talk about, I engage my nutritionist pretty early. So what does that mean? So peel your vegetables, peel your fruits. You have to sort of worry about fiber. So we have a whole, it's not a brat diet, but we have like a diarrhea-free helping kind of diet that we use for this particular agent. This is a nice tool. Oh, again, it's just going on its own. This tool, I encourage you guys to write it down. It really helps in terms of understanding the side effects of some of these drugs. And this is another really nice tool. You can use a little QR code here that we got real good looking at restaurant menus with during the pandemic. But print it out. And these are questions that you can ask your doctor or your team. It's a communication checklist. And it doesn't have to just be for hormone receptor positive breast cancer. So the trend is these days, we're going to earlier lines of therapy. So now abemaciclib Verzenio is being used in the earlier stage 2, stage 3 lymph node positive type of disease. And we're getting about 1/3 more patients being cured by using this agent for 2 years of the 5 years of an anti-estrogen. There is a newer study too, the NATALEE study, that is looking at ribociclib. And that's just 3 years of follow-up, 3 years of a drug. So it's very immature. I have to admit, though, that the high-level thing that we need to pay attention to is cost. So when you start doing the cost analysis of using, for instance, ribociclib in earlier lines of breast cancer, maybe about a 3% benefit for taking a pill for 3 years, the cost per patient is about $250,000. Now, insurance may cover a lot of that, but you guys have probably all experienced these pretty hefty copays. You know, you get in these donut holes and then January comes around, you got to do it all over again. You know, it's just so hard on patients, so hard on their families. And then there might be delays. Maybe you don't get your drug for a month and a half. Well, you know, cancer's partying during that time. So what are the impact of the CDK inhibitors? At least in the United States, I'd say first-line therapy for hormone-positive breast cancer in combination with either an aromatase inhibitor or Faslodex. But, you know, then what happens? So you get through maybe, hopefully, 4 or 5 years, and then the disease gets too sneaky. So do we have any New Yorkers from the city in the audience? Oh, there you go. All right. So you probably know how to get from Grand Central up to the Met or even the old FAO Schwartz. I liked it better when it was across from the park as opposed to Rockefeller Center. But there's lots of ways you can get there, right? So you can, I think that's Madison Avenue, that green thing or that blue thing. You know, so you could take a car, a lift up Madison Avenue. You could walk on Fifth Avenue. That's a nice walk. Walk on Park Avenue, take a bike, whatever. So you can imagine these are all different above ground ways. So maybe extracellular receptor types of targeting things for cancer. So then what happens? Well, you know, cancer gets sneaky. It says, oh, okay, well, Park Avenue is closed. Well, I'm just going to go take Fifth Avenue. Detour, 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 detour. Let's make mutations. And guess what? We can go underground and we can take the subway. And so that's how it travels, right? I think that's the Lexington. Is that the green Lexington line there? City lady? All right, all right. So anyway, I just want you to think about that when I talk about all these complicated pathways here. So in terms of one of these pathways that the breast cancer uses, the underground subway, there's the PI3 kinase, AKT, and mTOR pathway. And we know for both HER2 positive breast cancer, it is a mechanism of Herceptin escape using mutations in this pathway. Similarly, for the hormone receptor ER/PR positive pathway, it's also a mechanism of endocrine resistance. Now, about 50% of breast cancers harbor these mutations. It's about 40% PI3 kinase, about 5% AKT, about 5% mTOR. And you can see here, this is on the inside of the cell. They do work with estrogen. So when you think about different combinations, we're using these agents with other types of estrogen blocking strategies. And we have drugs for that. So we can basically stop these cancer cells from going on the subway. So here's an complicated slide of our NCCN guidelines. There are patient versions of this that are not as complicated. It's a free, they don't get lots of junk mail. Just put your email in there and create a password and you can look at some of this stuff. And these are updated at least once a year, if not twice. So I'm going to talk a little bit about CAPI, capivasertib, and elacestrant, but you can see here that there are lots of targeted therapies. And the nice thing now is we don't necessarily have to go back and biopsy a tumor. So it is really important at any metastatic diagnosis and or a progression to really understand, have the receptors changed, what's changed about the cancer. But now we have blood tests where you can actually search for these things. And Caris, I think maybe since George came, even has a HER2 measurement in the blood. So these liquid biopsies. This is not yet FDA approved. I just wanted to let you know that this was pretty exciting at our San Antonio Breast Cancer Conference in December. So this is looking at really high-risk patients. These are patients who progressed in the early breast cancer setting, who either had tamoxifen, about 40% of them were premenopausal, and within about 12 months, they've already progressed and become stage 4 or advanced. They did have to have a PI3 kinase pathway mutation. And basically, it was looking at that first-line CDK combination that I explained a couple slides back, plus now a third agent, a targeted PI3 kinase inhibitor. And this was the money shot in terms of the benefit. So in terms of response rates, more than a doubling of response rates, shrinking tumors, and also more than a doubling in progression-free survival and more than 50% improvement in disease recurrence rates. Now, I mentioned earlier on that schematic that pathway can also crosstalk, not only with estrogen, but also with the insulin growth factor receptor pathway. So some of the side effects really resolve around hyperglycemia. So the patients that were chosen for these trials had low hemoglobin A1Cs, they had low fasting glucoses, because we've known from a different PI3 kinase inhibitor, alpelisib, or also known as Piqray, that that is a side effect. What is commercially available now is CAPI. Now, CAPI is an oral AKT inhibitor. So I mentioned it's PI3K, AKT, mTOR. They're all part of the same, basically, Lexington subway line, right? They're just different stops along the line. So this looked at a population that was hormone receptor positive. Again, no diabetes requiring insulin. And basically, it was either the butt shot, fulvestrant, plus this AKT inhibitor. And what we saw here is that there's also improvement over just the fulvestrant or Faslodex. So a doubling of progression-free survival, and this was FDA approved just right before Thanksgiving. Side effect-wise, less hyperglycemia, some rash, some diarrhea, but overall this oral pill is relatively well tolerated. We look forward to seeing more combination data. It's starting to look a little bit like multiple myeloma in terms of all the different, triplets, and pretty soon maybe we'll be getting to quadruplets and stuff like that. I touched upon some of the toxicity here, some stomatitis, some diarrhea, because remember it's a pill, so you're going to get some cross bystander effect in terms of side effects. Kind of one of the last approvals that I'll talk about in 2023 is a drug called elacestrant. So I mentioned the butt shot, 2 of them, 1 in each cheek. That is what's called a selective estrogen receptor degrader. So how do we target estrogen? Well, you can get rid of the food, which is the estrogen, and that's basically what aromatase inhibitors do. So aroma means ring in Latin. You have a scaffolding of basically any hormone. Cholesterol is a building block of testosterone and all the hormones. And there's an enzyme called aromatase that comes in, throws a ring on the molecule to make estrogen. Aromatase inhibitors stop that from happening. So basically, no food, not making estrogen. Well, that's one way to do it. Well, these cancer cells, again, they're super sneaky. They use their little estrogen receptors to go out there and get that estrogen food. Well, what else could they do? Well, they could mutate the receptor. You can have an ESR1 mutation. Then that's constantly going. You don't even need food. It just, eats protein shakes or something. Just keeps going. Keeps going. Or you could completely chew up that receptor. You could degrade that receptor. And then it can't divide anymore, and it doesn't need food. So similar to Faslodex, elacestrant is a SERD, selective estrogen receptor degrader. Now, what's interesting about this, it also shows you how sneaky cancer is this is more of an acquired mutation. So patients have been on aromatase inhibitors for 3, 4, 5 years. Oh boy, that receptor says, I don't need food anymore. I don't care if you're taking away my estrogen. I'm just going to mutate my receptor. I'm going to make it on my own. I'm going to drink my protein smoothies. So this is an oral SERD. We think that it might be more biologically available. It's less toxic overall, and it's not a pain in the butt. And there's many of them out there now. And we can pick these mutations up in terms of this ESR1 in the bloodstream. So this was the EMERALD study that looked at that. And these were patients who basically had still estrogen-sensitive disease, randomized to either elacestrant or the shot. They had all had prior CDK inhibitors, so really more second-line, third-line hormone receptor positive. And again, busy slide. Bottom line is this is FDA approved since January, and it really seems to work in patients that have had a longer run in the first line with a CDK inhibitor. So have been on that for at least a year, year and a half, etc. Not those fast progressors. And so that's kind of where I've been using this drug. You can also use it if there's a co-mutation with PI3 kinase. So what are some of the side effects? I didn't touch that much on the aromatase inhibitors, but all these things have side effects, and we have to think about that. All right, so home stress. I'm going to talk a little bit about immunotherapy, which is more relevant in the triple negative breast cancer circumstances. So, our immune systems are pretty darn amazing, right? Like we identify foreign things, we identify bacteria, we identify viruses, and we say, get out of here, right? So we can find them, we can identify things that aren't self, and then we say, you don't belong. It's kind of like Trump at the Mexico border, you don't belong. But what do tumor cells do? Well, they turn off T cells. Okay, so now the T cells can't go out there and surveil. The other thing they do is they use PD-L1 and they hide themselves. It's like a little invisibility cloak of Harry Potter, right? They go around, they just hide themselves, or they disguise themselves as self. So if your entire inside of your body, when you're in your mom's belly, is yellow, well, a cancer cell comes in and says, oh, everybody's yellow. I'm going to be like little Paddington and put on my yellow raincoat and my yellow hat, and then the immune system can't find me. So that's what they do. So again, great work here. Another Nobel Prize to Dr. Allison, who was in my Berkeley backyard there with his Nobel laureate parking spot. We have about 7 or 8 of them. I think Stanford only has maybe 2. But anyway, I do work for Stanford. But at any rate, so pretty remarkable work. So game-changing in multiple types of tumors, especially in melanoma, which when I started my career, you're lucky if somebody could live 9 months. Now we have long-term cures with immunotherapy in melanoma, and similarly in kidney cancer. So in breast cancer, we are using it in the triple negative setting. Pembro or Keytruda is a anti-PD-L1 antibody. This was the keynote study that formed the approval in the stage 4 setting, added to chemotherapy. And really the best benefit is in patients who have a high CPS score, combined positive score for this PD-L1. So they really express it. Granted for full approval, again, during this pandemic in 2021. So how do we put all this together? This is a whole lot of data. So these are sort of the treatment roadmaps. So I talked a lot about hormone receptor estrogen positive disease. I talked about the newer PA3 kinase mutation that maybe can be used in the first line when there's some endocrine resistance. Talked about CDK inhibitors. I talked about the PI3 kinase AKT mTOR pathway with this CAPI oral drug. I talked about elacestrant, that eating up of the estrogen receptor. I talked a lot about antibody drug conjugates, and then of course clinical trials. Here's for HER2 positive breast cancer. We touched about TDXD. We talked about tucatinib, homegrown here, Seattle Genetics, that oral pill that can get up into the brain. Clinical trials, of course. I talked a little bit about immunotherapy in the roadmap for triple negative breast cancer. I did talk about SASE, but more in the newer approval for hormone receptor positive, but it is also approved in hormone triple negative breast cancer. So what are some of the conclusions? Boy, this is complicated. It's confusing. We need road maps. I think it's not even the New York map anymore. It might be more like Paris with all these little side streets that are this big. Personalized treatments, biomarker driven. Antibody drug conjugates, even for, it doesn't matter if it's breast cancer, colon cancer, whatever kind of cancer, we're really targeting that pathway the cancer is using. I touched upon really quality of life, not just quantity, some of these endpoints that we're seeing incorporated into clinical trials. Multiple lines of therapy now. As I mentioned, when I first started in my career, there was really not much third line, not much fourth line. You kind of recycled multiple types of chemotherapy, hoped for the best. Our treatments are moving up earlier, hopefully causing more cure. And there's much, much more to come. I think here we are with Komen. I think in front of you, you have little postcards. So what can you do? How can you kind of give back or give forward? So Share for Cures is a Komen initiative. It's a breast cancer research registry. And what's nice about this is it's institution agnostic. Doesn't matter if it's Stanford or Harvard or wherever, Hutch, anybody can participate. And it really, at the end of the day, we have the same mission to kick cancer's ass. So how can we be better at doing that? So please think about that in terms of sharing your information. The other thing I think that my New York colleague over here commented on is I live in Oakland, where we have a diverse community, but patients are getting on clinical trials that are Native American, Black, whatever color, and whatever demographic. We don't have enough information. Are the drugs metabolized differently? Are there different toxicities? Are there different side effects? So that's another thing that's really a call to action in terms of help there. I'm going to put in my own plug. I'm giving a Caring for the Caregiver roundtable in a couple weeks here. It's on Zoom, so you don't have to be in a room. You can be online. It's May 21st at 6 p.m. And it's several of my patients shared with my palliative care colleague, Dr. Joe Hanna. And this is family members, your support team. So you guys are really the unsung heroes. So everybody who's here supporting a cancer patient, holding their hand, you guys are the co-survivors. And you're the ones who take patients to appointment. You know, you make sure they're taking their medication, you fill their pill boxes, you go the grocery shopping. So you guys are really the co-survivors, and we're all caregivers at some point in our life. So please join me. I'd love to see some of your faces. There's a QR code. You can always reach out to the Komen team and get that as well. So I'd just like to say thank you. My humanity is bound up in yours, so we can only be human together. Thank you.
Yeah, so this is definitely a challenge. So a different trial I didn't present here, but we are using Keytruda in the neoadjuvant setting with the purpose to shrink tumors more, and it is PD-L1 agnostic, so you don't have to have the CPS score of 0 or of greater than 10. There are other ways to kind of gauge whether or not this tumor or tumors could be immunotherapy responsive. So there's something else called tumor mutational burden, TMB. So I do have patients who have maybe a CPS of 0 or 1, but they have intermediate to high TMB. And I have been using it in that circumstance. So it's not necessarily completely off the table. Triple negative breast cancer continues to be a challenge, and we have, sacituzumab now. We have other antibody drug conjugates. So we are getting a little better in terms of how do we target these pathways, but in terms of immunotherapy, I think some of it is, we do a lot of these peer-to-peers where, I'm convinced it's like an endocrinologist in some basement wearing slippers because they have no knowledge of cancer treatment and stuff, because the questions that they ask are not very sophisticated at times. So I have used it in triple negative breast cancer that is CPS 0 or 1. Yeah. Sure. I know. I'm not sure the last time you had genetic testing done. Is it complete panel testing, both germline and genomic? You've done it all. Okay. Variants of unknown. Okay. Mm-hmm. Inflammatory breast cancer is a real issue too, depending on which part of the world. A lot of that in Texas. MD Anderson does a lot of work there. I think that it doesn't necessarily have to be a BRCA1 or 2 positive tumor as well. So if there's a PALB mutation or even an ATM mutation, we are using PARP inhibitors in those circumstances. But you're right, there's so much more work to be done. And there are a lot of unmet medical needs, especially in the triple negative population. It sucks, and I'm sorry that you're going through this. Have you been able to participate or find any clinical trials? Okay. Okay, good. What else you can do? Yeah. Yeah. We're behind. We're definitely behind. Yeah. Correct. Exactly. Good question. It can. So if you have a family inherited BRCA1 or 2 mutation, we can pick it up in the bloodstream. Signatera also has a blood test that can be run at the same time called Natera, and that can pick up germline mutations as well. Yeah, so we often use them both, and it depends. So ESR1 mutations seem to be picked up a little bit more in the blood. So I think it depends on what you find. Nobody wants to get poked all the time, and it depends on accessibility. So I think it was mentioned earlier that patients who have bone-only disease, it can be pretty hard to re-biopsy one of those lesions, and it may or may not be involving the bone marrow itself. So it's really a mix. I mean, I think it's easy to do these liquid biopsies, but it's only as good as what you can find. No. You can, no, I mean, you can go, well, it depends what the intention is. Are you looking for HER2 low? I mean, you can go back to a breast cancer surgery from 15 years ago. So I think it depends on what your next line potentially might be in terms of what treatment options are being considered. But yeah, you can go back. I mean, most pathology departments hang on to the blocks in formalin for at least a decade. If not, maybe they're in some storage facility. It might take a couple weeks to get it. But, so it depends. It depends on, and it also depends on how much tumor tissue is in that block. So, other questions? Was that confusing? Was that? Okay. It may not. Mm-hmm. 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 What's new? Yep, that binary. We're living in a non-binary world these days, right? I have 2 non-binary children. Mm-hmm. Well, remember the ad hoc side of the pig? Depends on which part you're getting. Okay, yep. So, was it 0? Well, okay. So here's another piece of advice. I was lucky to work with a lot of masters in the HER2 space. So I also worked with Mike Press, who's a pathologist at USC, and he has the world's #1 lab for looking at HER2. So you can ask, can I have my pathology reread by Mike Press at USC? And they. Right. I mean, so you have to also understand, I mean, there was another study that looked at sort of even interpathologist heterogeneity and subjectivity, and you can get 7 pathologists in the room that have some different takes on stuff. So it doesn't hurt to have a second opinion, or, I mean, whenever, like if you came to Stanford for a second opinion, we reread everything. Our pathologists get the slides, we reread them. At USC, Mike Press, P-R-E-S. Mm-hmm. Yeah. Yeah, I think it's easy enough to request. Sure. Any other questions, comments? Thank you for hanging out all day. This was a long, rainy day, but maybe the sun will come out a little bit. Good. There's hope. And, you know, cancer doesn't sleep, so neither do we.
Thank you, Dr. Dolezal, and thank you all for joining us today. An incredible day. I learned so much, and I take that same sentiment home on my drive to Portland. That we're closer to a cure today than we were yesterday. So we'll keep working. We'll keep working together. A few things on your way out. There's still some snacks. Please feel free to take some home. Also, a gift from us from the walk team. A buff that you can take with you, wear and display as you would like. September 28th at the Woodland Park Zoo. Would love to have each of you join us as we continue to build the breast cancer community here in Seattle. Again, thank you so much for joining. You'll receive an email with the recordings when those go live on YouTube, and then the decks as well. So look out for that. We'll also ask for some feedback for the day if you have any suggestions. We would love to hear them for future gatherings. Thank you all so much. Only if you walk in, look at zoo animals.